dear colleagues and guests. First of all, I would like to congratulate you, to welcome you on behalf of Lithuanian Dental Chamber here in Vilnius. And I would like to express our huge gratitude to all of you for accepting our invitation, for being here, for sharing your experiences. Today, we will be talking about financing of oral health care in our countries. However, I strongly believe that first of all, we would like to emphasize the importance of oral health promotion. And unfortunately, today we are paying to our patients mainly for dental neglect, I would say, not for taking a proper oral health care. Because millions and millions euros is being paid for restorative dentistry and much, much less for preventive dentistry. And we all know very well that majority of dental disease are absolutely avoidable and preventable with certain behavior from the side of the patient. So, because of this, I think that our main enemy we should fight against is not microbes in our oral cavities. However, myths and disbeliefs in minds of our patients. That's why I'm very happy to see today amongst us some of our Lithuanian politicians from governmental side and parliament side who are responsible for policy making in oral health care here in Lithuania. Our national oral health promotion program is on the way, and I truly hope that this event will have an influence on successful preparation and later on, subsequently, on successful implementation of this program in Lithuanian population. And I would like to invite to say welcome in word our representative of Committee of Health Affairs from Lithuanian Parliament, Dr. Jurgita Sejonienė.
Thank you, Professor. I think you said all the most important things. From my side, I also greet all of you who is taking part here today, organizers, participants, speakers, all attendees here on site or remotely. I think it's very important to talk about oral health. It's very impressive to have almost all Baltic countries here today, and all we share the same problems, or we have different. Also, we have different experiences, and it's very important to share good practices and our problems in order to make differences. For example, in Lithuania, I do not neglect, we have a lot of problem with oral health, and I hope that today's conference will make a significant implement on our decisions as policymakers, as politicians. So let's have a good time. Thank you all. Thank all of you.
A President of Council of European Dentists, Dr. Fredislav Lisbier. I'm sorry for my pronunciation. And I just want to repeat, well, because of a microphone, that we are very proud and honored to have you here today. So, and I would like to invite Dr. Freddy to present the oral health care in European Union.
So, thank you very much, and good morning, everybody. And it's an honor to be invited to this conference. Could I please have my slides on the screen? Oh yes, thank you, thank you. It's really an honor for me to be here today and talk about the financing and the delivering of oral health. And although I come from Denmark, I will today be wearing the CD president hat, and I will try to give you an office that I run in Denmark. And I have been a dentist for almost 40 years, so it's a long, long time ago since I left dental school. After that, I went to Germany to work. We were at that time in a situation in Denmark where there were too many dentists. So not to be unemployed, we decided, me and my wife, to go to Germany and work there for 12 years. So I'm very familiar with the German way to do dentistry. We went back to Denmark, both of us, taking over the leadership of a public dental office only working for children. In Denmark, we have a different system as you have everywhere. My wife will talk a little bit about that. But I was for 5 years the chief dentist from a small municipality, only working with public dentistry for children. Then we decided again to work with adults and bought our own office and have been running that for more than 20 years. So just to let you know that I'm a full-time clinician, I'm also a little bit of a politician, so allow me from time to come with some political statements. I'm not a scientific, so if you want to stick deeper into the material, I'm sure there will be many else to be asked. So, and the next thing to talk about is a little bit about the CED. What is CED? Many of you are familiar with that, but there will also be some among you who are not. Yeah, we are representing the dental profession in the European Union and in the 4 countries who have very close connections to the European Union. So you can say we are representing close to 340,000 dentists around all the European countries. We were established a long time ago in 1961, at that time as a liaison committee to advise the European Commission about matters related to the dental profession. And what do? Yes, we promote high standards of oral health, dentistry and dental health care. And we also promote the interest of the dental profession. No doubt about that. So you can say we stand on 2 legs, but we also do that as a human being. It's very important to move. So I don't see any contradiction in promoting the interest of the dental profession and at the same time working for high standards of oral health dentistry and dental care. They are really linked very close to each other. And we have a dental board. We are 8 members of the board, representing 8 different countries in Europe. Just to let you know, we are working so different. So we need to have a board with many people that we can have all the different systems presented and then represent also the big diversity of how we do dentistry in Europe. We have 2 general meetings, one in spring and one in autumn, where everybody comes together talking about dentistry. And we have a Brussels office with 4 people employed to take care of the daily business. We have 5 working groups, and you can see we deal more or less with everything about dentistry. Education, professional qualification is very important because we have a recognition across the European countries, so we have to do that on a level. But you can read that all about on the screen. I'm not here to talk about the CED. And all our policy statements, there are a lot of them. I won't go through them. You can find them on our webpage, and we also have a public part of that. So if you want to move a little bit deeper, just consult our webpage or consult our office in Brussels. They will take care about that. So, but the topic today was to talk about the delivery and the financing of oral health care in Europe. And as I already said, this is really not an easy task to be given because we are all doing that differently. From an overall point of view, I think we are having a health system for 3 reasons. We want to deliver prevention of disease, no doubt about that. We already heard that in the introduction. That is maybe the most important thing about having a health system. But again, somebody will get sick. So we also have to do treatment and take care of the sick. That should be, in my opinion, the second purpose for having a health system. And then we have a third one. This is about financing. Yes, if we don't have a health system, we will maybe ruin families paying high doctors and dentists bills. So I think that's the reasons everywhere why we have built up health systems. This is a little bit about solidarity, also to prevent disease, but also to take care of the people who are going to be sick, because there will always be sick patients out there. And how have we organized that in Europe? Yeah, we are using 3 different models. We have the national health system. That's the system that you know from the Scandinavian countries, also the country where I myself come from. In Denmark, we have a tax-funded system. We have most of the healthcare workers are employed by the public in public-owned hospitals, and that's also the way they do it in Norway and in Sweden and in UK. It's also called the Beveridge model, after an Englishman who made this system in the UK shortly after the war, if I remember right. But so I know a little bit about working in a national health system model. But as I said in my introduction, I also have worked in Germany, and they are using a different model called the Bismarck model, where we have sickness funds, where the payment comes from payrolls. There is the employees and the employers are paying a part for this system, but the system is still under very strong control from the government. I'm sure that Dr. Benz will say that's exactly the system in Germany too, although the Bismarck model is different and you have your sickness funds, but it's not without control from the government. Am I right?
Yes, sure.
Yeah. And then, of course, we have a mix of those 2 systems. It's sometimes called the national health insurance system, where it's not paid through taxes, but we have a system where there is maybe only one big insurance who is taking care of all the things, but the deliverers are often private hospitals or private doctors and dentists. That's about the systems. And the fourth one I forgot, you can also have totally paying out of the pocket, but we don't use that model in Europe at all. But we see that in third countries out there. There is absolutely nothing. So I have worked in 2 of those systems, and none of them is pure. If you look to my own national system, we can say, yes, it's maybe a national health system when we talk about general health. But you will hear when we talk about dental health, this is more or less an insurance system or out-of-pocket payment system. And that's also what we see everywhere, that they are not pure. There are mixes of things in there. And you will not hear me saying that one system is better than the other, because this is only a system. It's also about the processes and the people working there. So there are good things about one system and there are bad things, and maybe we can figure out to do it the very best way, but I'm not so sure that we can get to a uniform opinion on a European level. It's my experience working with that for so many years that everybody think that exactly the system that we have is the best one. And again, I can only tell you about my clinical point of view. I'm not a scientific. I haven't done research about that. So, but if we look so from overall trends, you can see to the left, there are some structural changes in the workforce, privatization, group practices, and focus on treatment with signs of shift towards preventive therapies. I'll talk a little bit more about that on the next slide. And then we have about the financing, and this is more or less everywhere the same, that vulnerable population groups, they are covered. It's certainly the case for children. The ways to finance it, I already talked about that. But seen from the outside, 1/3 come from public sources and 3/3 is out of pocket, with big differences. We have countries also in Europe where the out-of-pocket payment for dentistry is close to 100%. And that's the case in Spain and in Greece, for example. We also have a country where the out-of-pocket spending, it's about 30 to 40%. That's the case in Germany. So there is a very big variation across Europe. So if we look a little bit about the trends in the EU, privatization of dental care for us working in the Western countries, it had always been the situation that if you look away from the Scandinavian countries with Sweden and Finland, where they always had a very big amount of dentists working in public offices, it was more or less everything private in the Western European countries, and in the Eastern countries you had more a public model. But that has changed a lot after 90. So if you look from an overall point of view, 80% of the dental care in Europe is done in private practices. So then I also say there is an increased number of dentists. Yes, that's true if you go to the statistics and you count the numbers for Europe at all, you will see we have an increased number of dentists. But we have many countries where we really face a decrease, and we are running into a big challenge in the future because we have a group of, like me, elderly dentists, who will retire in the next 5 to 10 years. In my own country, 20% of the dentists we expect to go in pension in the next 5 to 10 years. And we don't educate that much dentists. So in Denmark, we are talking about lack of dentists. I know they are talking about exactly the same in the Netherlands. I still have good connections to Germany, friends working there. They are also telling about a situation where there is not enough dentists. So again, increased number of dentists, it's for an overall European point of view. And this also leads to migration. You can see in many countries there are a lot of dentists coming from neighbor countries, maybe because they speak the language and are going to work in other countries where the conditions are much better. They maybe earn a little bit more. So we see a big movement of dentists from the southeastern parts of Europe to the western countries, which of course helps us in the western countries where we are in a lack of dentists. But again, is that fair that some countries educate dentists just to let them move to other countries? You have spent a lot of money doing the education. You have invested, in my opinion, a lot of money in a young generation who then leaves your country. Full understandable, because the working conditions maybe are better in other countries. So the CED point of view is you have to take care of the healthcare workers, the dentist, the dental hygienist, the dental chairside assistant that you need in your country. Don't expect that you can import them from other countries. But again, this is maybe with thinking, because the real world, we see a big migration of dentists. We also experience a situation with cross-border dentistry. And if you look to the right, you can see we are talking about both dental tourism and cross-border healthcare. These are, of course, close linked to each other, but not the same. Living in a country with borders close to other countries, it's totally normal that people move over the border to have dental treatment or healthcare treatment in another country for many reasons. One of them could be, while we have a big out-of-pocket payment in dentistry, that it's cheaper. It's maybe not a problem for patients living in the southern part of Denmark, going for Germany to get dentistry done there. Same quality, they maybe speak the language, but it's 20% cheaper than in Denmark. They do that on a regular basis. They visit their dentist once or twice a year. Many of the dentists in Germany, at least in that part of Germany, speak Danish. We don't see any big problems about that, also because we are European dentists working together. But if you then move to the other part, that what we can call dental tourism, people buying a flight ticket, moving to Hungary or Czech, who are two of those countries where they do a lot of dental tourism, going to specialized clinics for having delivered dentistry very fast and often big prosthetic works without good preparation, without aftercare. Then we are really talking about dental tourism, what is totally different. And there we see a lot of problems. So we have a statement paper, and I don't want to talk more about that now, but if you need to read a little more about the challenges and the traps that we see with dental tourism, then please consult this paper. And there is also, of course, a situation about corporate dentistry, a growing industry in Europe. I know this is a specific topic for today, so I will not elaborate much about that, but maybe I can have some comments when we come to your pages. So, and we also already heard in the introduction here that the way we do dentistry, and maybe always have done that, is based on treatment and technology. And not everywhere there were public health and prevention care. And I'm very happy that the WHO now had tried to push in a direction where we could integrate dental health care in more general health care. Because if we want to do more as we do for now, it is, in my opinion, the only way that we can do it. We have, of course, in dentistry, by ourselves, worked a lot with prevention. Different levels in different countries. You will later hear about the Danish model, and we have really had a model where we did a lot of prevention, group prophylaxis. But you will also hear we are now leaving this part. We are not longer doing any kind of overall group prophylaxis programs in Denmark. Why not? Because we have moved so much that it's not longer necessary. So I am not saying, please really don't misunderstand me, that the WHO approach is a wrong one. It's the right one, because it's the first step to take. When you then have taken this step, you can do something else. It's really important to understand that we are not talking about one size fits all here. We can have an overall program, but we have in each country to look carefully where we stand and then find our way. And as you also heard me saying, there's no system better than the other one. It depends on how you use the system. So prevention, yes, no doubt about it. Maybe we shall more say that, yes, we can prevent a lot of dental disease. As a clinician working with 40 years with dentistry in a country where we have done a lot for prevention, and we still have a lot of dental disease. So I prefer to say we can maybe not prevent dental disease, caries and periodontitis, but we can control it. And that's totally different as treating it. But maybe it's only about words, so don't let us talk so much more. Oh, I just forgot one. Oh, can I go back here? This one. So, we come from a past where all over, at least in the European countries where we had private dentistry, we come from smaller private practices, often practices with one dentist, maybe one or two dental chairside assistants. That was the way we organized dentistry back in Denmark 40 years ago. And as you know, I'm familiar with the German system. It was also the way you organized dentistry in Germany. in many, many countries, we have seen a movement towards group practices. A movement started up 25 years ago, and for many reasons. One of the reasons is that doing dentistry need a lot of investment. The technological development during the last years requires us to invest in so much equipment that we maybe need one machine for doing something that can be used by one dentist, but it can also be used by 4 dentists only with one machine. So this synergy forces us to work together in bigger groups, no doubt about it. We will have also seen a change in the administrative burden, what is required for us to doing dentistry. I still remember as I started as a dentist, doing dentistry, doing drilling, extraction of tooth, and then I wrote a little bit on paper. It was only a few words, that was everything. Now I have to write more or less a novel. So the administrative burden had raised immense. In my dental office, I use 70% of my time doing what I'm educated for, helping patients doing dental health care. But I also say now I'm using 30% of my time with administration. So when we talk about numbers of dentists, we also have to face that now I cannot use 90% of my time delivering dentistry. So it's very difficult to compare how many dentists do we need. If we look at that, we also have to take into consideration that we are now in many countries working with dental team. So it's easy for us, many of us here are dentists, to talk about dentistry and then about dentists. But we don't have to forget that we also have dental chairside assistant and dental hygienist course over Europe. How we use them is very, very different. We have countries in Europe where we have 40 dentists per 100,000 inhabitants, but we also have countries where we have 120 dentists for the same population. We can also do it the other way around. In one country, one dentist have to take care of 2,500 patients, and in another country, he only has to take care of 100 patients. But can you compare it that way? No, you cannot, because in those countries where there is a lot of patients for one dentist, they are maybe in a situation where dental disease is not that high. They could also be in a situation where they use a lot of chairside assistants or dental hygienists, and that's the reasons why you can see my 2 words up there, delegation and substitution. Both are used in dentistry in Europe. And used clever dental team, in my opinion, is really the future. But again, there are also traps in there. If you don't use it right, you will have problems with patient safety and you will have problems with the quality. So how much money do we use? Because that was the other part of it. If we look from the overall point of view, dentistry is the 3rd if you rank. Only diabetes and cardiovascular diseases are requiring more money than dentistry. So you are, of course, totally right. If we can do more prevention, if we can achieve more by doing more prevention, or with my words, maybe not only prevent, but control, accept that we in some kind of way have to do with diseases that are out there that can be controlled, we can indeed save a lot of money. A small filling is much cheaper than a root channel treatment, a crown, and maybe later an extraction and an implant. So yes. And how much do we use? Yeah, it's very different. You can see from an overall perspective, 5.1% of the total health costs are used for dentistry, but there are big differences. Maybe you cannot see the exact figures in my small table there, but I will hand over my slides and I will give you a way to find the exact numbers. I think that's much better. And if you look down to the left, I have quoted European Observatory of Health System and Policies a couple of times today, and I'm very happy that we have one of the authors here. So if you have the opportunity to read this wonderful paper they published here in 22, please do that. There is so much information in there that's really useful. As I can only thank you, Jesus, for doing something so valuable. It's very useful for everybody. So from an overall point of view, 2/3 payment comes from out-of-pocket payment. Is that a problem? In some countries, it indeed is a problem. It indeed is a problem. And it's again, I fully recognize that you can pay it by yourself, you can pay it through taxes, you can also pay it through insurance fees. In the end, there's only one to pay, the citizen or the patient. The money shall come from somewhere. I fully understand. So what do you want? Do you want to pay the dentist by yourself? Or do you want to pay more taxes? Or do you want to pay insurance fees depending on the system that you're working in? Yes, I fully understand. But this is really about, do we want to care for every citizen? Do we want to work with a model where we build in solidarity? And if yes, then we have to do something about out-of-pocket payment. Because otherwise, I can see that in my very wealthy country, it's really a wealthy country, and we have done a lot for dentistry. The rich people, because we have a very high out-of-pocket paying in Denmark, can afford to have everything from best quality. The poor people can also have good dentistry, but not the best quality, even in a very wealthy country. That's how it is. And yes, everything is changing. Now we are here because you want to change something in Lithuania, and you can see health system is always, to use your word, Jesus, in transition. There are changes everywhere the whole time. And some places they go up, have budget increases. In other countries they are going down. And again, we are facing big problems out there also because of those structural changes. And maybe one last thing to say about that is, don't expect that the future generation of dentists, dental hygienists, or dental chairside assistants want to work that many hours that many of us did. The work-life balance expectation from the next generation is lower. For me, it was not a problem working 50, 60 hours doing dentistry when I was young. Also not for my wife, that had nothing to do with gender. But don't ask the young generation to do that. They won't. I have nobody employed in my dental office who wants to work full-time. So again, to compare how many dentists are necessary for the future, that's not so easy. How many hours do they want to work? And they also want to work in group practice. They want to share not only the financing and the administrative burden, they also want to share their knowledge on how to do dentistry, work with other peoples. So maybe it's also a little bit a problem, and I'm saying that because I'm sitting here very close to the door, that many of us doing politics for the future, we are old men. That's maybe not clever, but again. So you can find a lot about how to do dentistry in Europe if you consult our e-manual of dental practice. I must admit, you can also see that on the screen, we are talking about 2015, so it's a little bit old, the data that we have in there. But we are doing a new and we hope that we next year can bring it on the market. And if not, I already said to you, we have this wonderful European Observatory. There's a lot of information you can pick up there. So I come to my conclusions. Dental care continues to be treatment dominated by solo practices, but there is a shift towards more prevention and provision in group practices with new dental professional roles. No doubt, I said it again, dental team is the future, not only for financial reasons. The young generation want to work that way, said from an old man, I admit. And the rest you can read. I think I have talked enough, and I'm running out of time. You can have my slides. Thank you for letting me speaking to you.
Thank you very much for your beautiful presentation, I would say, Dear President. So I would like to remind that we will have a closing and summarizing session at the end of this conference. So please, if you have any comments or questions, so just leave it for later, okay? And as I've mentioned in the beginning, we are very happy that today we have the politicians of the highest level here with us. And I would like to invite for his speech our Vice Minister of Ministry of Health of the Republic of Lithuania, Mr. Aurimas Pečkauskas, and he is going to present financing and legislation of oral healthcare in Lithuania from the perspective of Ministry of Healthcare.
Thank you. Thank you very much for introduction. As mentioned, my name is Aurimas Pečkauskas. I am Vice Minister of Ministry of Health. And I don't know about technical issues. Can we have my slides on the desktop and the stick for changing them? And while we're waiting that, I am actually very honored to be here in this distinguished event. Thank you very much for invitation. It's not that often we can actually discuss issues related to dentistry in live matter in this high level event. So really thank you for invitation. And what I'm presenting today, it's the perspective of financing and legislation of oral care in Lithuania from ministry perspective. The presentation will be a little bit maybe from observatory side, let's put it that way, just looking at where we stand now with some insights where we could maybe move later on. So first of all, I want to start with a little bit wider approach of the system of our country, about how all the strategic documents are being born in our country, and where our part of health and of course also dentistry stands in. And also this slide represents that we are facing quite a lot of issues and challenges as a ministry, because since 2 years ago we have a lot of changes in all the strategic planning of all the projects, all the investments, and all the reforms we are planning, we are going through. So this is the schematic slide of how it works. We have a big document, National Progress Plan, which is the main document for the country for a 10-year perspective, and below that we do have a shorter versions, let's put it that way, of plans which are covered with concrete initiatives which are being delivered to take that change, to take effect of the change. And moving forward, so moving to the health part, we do have the task number 2 in the National Progress Plan, which talks about the healthcare in general, and we do have 2 subtasks under that. which talks about, one of them is development program for health maintenance and promotion, and another one is development program for improving the quality and efficiency of healthcare. And this is the part where actually all the healthcare services goes under, including dentistry as well. Because just to mention why it is important what I'm telling you, currently Lithuania is going through the big changes in the healthcare sector. We are in the middle of the major reform of hospital healthcare institution reform. Actually, we just not long ago had accepted, thanks to parliament members, the law which actually allows us to go with that reform, and it is actually a very big issue which requires a lot of resources, not only in the ministry but also in all. It gives a lot of stress to all our healthcare institution network. So this is one of the reasons why maybe we are not so active in other fields of our current areas. So in the slide you can see main problems which we are describing in our strategic document. So ineffective primary health care and all other points. I maybe won't go through all of them, but I believe one which is very related to dentistry is exactly the ineffective primary health care. And we will acknowledge that, and we understand the problem, and we have some plans how to solve that at the little maybe manner. And I'm very glad that we can talk in here, because we need to find the more ways how to improve with this sector as well. So just one more slide to be added to the maybe more global perspective. So we understand not only in Lithuania, everywhere in Europe, we have problems with aging society. Some of the countries, especially our population, has a declining in numbers. We have a decreasing number of people of working age. Also, some recent problems occurred with high inflation and rising prices, and of course the external situation of war around our walls of the country are these major issues which are actually provoking us to move much faster with all the reforms of the healthcare sector. And of course, one more thing to mention, we do understand, despite that financing of our healthcare system is not enough of the finances in our healthcare system. I think we will account to 6.5% this year from as a part of GDP, which is very low actually. But even with these numbers, we do acknowledge that our resources are not used rationally in the country. So we need to improve that thing first, and then, of course, or together with that, think about higher finances moving to healthcare sector. And the last slide about the reform, and we are almost the last slide about the reforms. So what the healthcare reform is touching, so basically emergency medical care network, ambulance network, active inpatient care institutions, and we are creating a network for long-term care institution. And the main goal, I would say, of the reform is to move from inpatient care to outpatient sector, to providing much more ambulatory services. And we are working a lot with a network of primary, personal, and public healthcare institutions. And this is the part where dentistry comes in as well. So just a little bit deeper to that, what we are trying to do. So basically in all the regions of Lithuania, we are trying to improve the access to healthcare services, including dentistry as well. And we are trying to define the basic package of the services which must be provided from the primary healthcare. So we are talking about GPs, we are talking about psychiatry, and we are talking also about the dentistry in that package. Also with additional bit of day services and secondary ambulatory care as well. So what we are actually doing right now is trying to describe that basic package and how it should be delivered in the healthcare institutions in the regions. And one of the main, I would say, legislation documents or policy documents are on its way to be provided to the public for the discussions, and we hope it will be in the system in few weeks' time. So also we will ask help from our social partners. So moving from the reform, how the dentistry services are regulated in Lithuania in general. So basically, when we are talking about main regulation, the Ministry of Health is responsible for general regulation of primary healthcare. So we are talking about licensing, establishing regulation of funding. And we are not working alone in this field. We do have a National Health Insurance Fund, as from the first presentation. So just to put a link in here, Lithuania has one payer system. So we have National Health Insurance Fund, which in the structural organization has also territorial health insurance funds, which are responsible for the funding of primary healthcare in our country. And if talking about the governance structure, municipalities are the local government bodies which are responsible for local regulation of providing primary healthcare services. Also, in the laws, we do have a statement that all the patients has the right to choose healthcare institutions and healthcare specialists, despite the geographical station or other issues. So basically, patients' right to choose his doctor and the institution the doctor is working in. So moving from the policy point of view, I'm sorry that it's not so clear maybe in this slide. In Lithuania, we do have around 2,500 dental care institutions. We do have around 4,400 licensed dentists, and we do have around 1,800 dental hygienists in Lithuania. And yes, but we do have a problem. Well, we think that it can be considered as a problem, but that only a small part, it's only around 13% of all the dental care institutions have concluded contracts with our National Healthcare Insurance Fund. So basically, only these institutions, only small part of the institutions are able to take part in the financing from our National Health Insurance Fund. Also, it's what is worth to mention. Of course, I will go further about how the financing is provided for this small part of institutions. It is worth to mention that in Lithuania we do have the separate program for financing the prosthodontic treatment, and it is actually quite big numbers we are providing in this sector. So when we are talking about moving from treatment to the prevention, I think it's a quite a big number to understand, because it's quite a half of all money provided from the National Health Insurance Fund to the dentistry side is exactly given for prosthodontic treatment, which we all, I believe, understand is totally avoidable. And if you to look at the right side of the slide, this is the number of people who are actually allocated by their GPs to dentistry cabinets, and we see that most of the people are actually assigned. They do not always choose it. It's by default, general practitioner assigns them to dentistry clinic, and we see that half of the people, 1/3 of the people, I would say, is assigned to private service institutions, and much bigger number to national ones. So moving forward, if we look about the contracts which are being made between National Health Insurance Fund and institutions providing dentistry care, we see that around from these 330, we do have around 200 which are private and 130 which are public. And this number is quite stable for a few last years, I would say. I won't stop with that on that slide as well. I won't stop on that slide. It's basically the list of main legislation acts which talks about regulation of dentistry in our country. And this is just a note about how the contracts are being performed between the National Health Insurance Fund and institutions. So I believe we'll share the slides, and everybody who will want to dig deeper in that can do some reading. And so this is, I think, one of the very important slides. So the main principle, how it works in Lithuania, about the financing. So we do have a capitation fee. So basically, those institutions who have the contracts with National Health Insurance Fund and the patients who are assigned to these institutions are capitated, and basically money per capita is flowing to these institutions despite if we are using that or not using that. So this is, I think, the main problem we are having at the moment in our system, and we definitely need to talk about it and search for some wise solutions how to deal with that. And in the slide you can see the numbers. They are provided in euros, how much of the finances go per capita to these institutions. These numbers are definitely not high, but with that mechanism that people are not really using the money which are provided for them by National Health Insurance Fund and the solidarity principle, basically we have the system still working. And we are moving a little bit to the number side. So as you can see, the blue columns are showing how much of the finances are being allocated every year from National Health Insurance Fund, and on the right red stripe we see how our population is situated. So basically we had a quite big decline in the population, in the numbers of people being treated, and we see that the numbers of money dedicated for primary dental health care was growing through the years, and now we have around 53 million euros. So just keeping in mind that we are investing, as I could say, around more than 40 million for prosthodontic treatments. Another slide which shows how these millions are being split between the groups of children and adults. And as we can see, it's around more than 70% of that sum is being allocated to the adult treatment, and a smaller part for children. And as we can see, this is also a very important slide. So this is the number of people who receive the primary dental care services, and I'm talking about that one who is financed from the public service. And as you can see, adults reach around 360,000, while children is 270,000. So in sum, we do have around 600,000 patients who are using this money, and as we understand, our population is 2.8 million, so looking at that, it's quite disturbing. And as we can see, another slide maybe to support my statement about how the system works in here. We see that adults who actually goes to the public financing system uses their dentist for average 3.2 times per year and 2.4 for the children. So basically, if we have the payment of 20 euros per capita for the institution, and the patient comes average 3.2 times to the dentist, we can imagine how these numbers doesn't really add to one side. And this slide just shows a percentage of a part of a population who are going to the public finance institutions. And the last slide, I think, about the numbers. This is the actual numbers, how much money are being spent per person in the institutions which has the contracts with the National Health Insurance Fund. And as you can see, it is for adults it's more than 100 euros, and for children it's around 40 euros. And of course, these numbers also doesn't add up to the rate which are being deducted at the moment. And just to mention, we also in our system have some additional payments who go to the system, so payments for good activity results, and basically these payments are shifted towards the improving, let's say, prevention care. There are few bits and pieces where this money comes to the doctor's office, who also for that who has the contracts with the National Health Insurance Fund. So basically, in sites, what are we having? So although finance sum is increasing every year, we are covering only small part of population need for primary dental care, and model of financing is beneficial for only small part of population. Majority of population seek for primary dental care in private sector, which does not have connection with public insurance fund. Current regulatory framework is not really optimal for creating conditions for better access to oral care. Public resources directed towards treatment rather than prevention, and population altitude dentist is needed when there's something to treat, not for taking part to the prevention side. So these are, very open position, open statement, which comes from ministry. We really acknowledge that we do have some problems in the place where we can work on, and I think we need to do that together and move forward with that. Currently in the ministry, we do have working groups together with our social partners, and it is a very big thank goes to Lithuanian Dental Chamber for taking part of that. But as I mentioned already in my previous slides, I believe I need to admit that the work is quite slow in these patterns, so we really need to move a little bit faster in here. And what comes from these working groups, we do have some propositions of how we could change the financing model, moving from that capital payment. So maybe we should look at paying for a resident who is registered in the country, more payment, or changing the proportions for prevention services, allocating some health insurance funds money to that side, and of course moving a little bit with children and disadvantaged people to provide a little bit, taking a little bit of social aspect to the financing system as well. So we need to discuss about that. We need to move forward, and I'm quite hopefully looking towards the next year, and hopefully we will have results in this part as well. So thank you for the attention. I think my time ran off. So thank you very much.
Thank you very much, Vice Minister, for this thorough analysis of numbers. So, and I would like to introduce Dr. Jesus Gomez, and we're very proud to have him here as well. Mr. President has mentioned in his speech about beautiful work they did, and actually we read it. So that's why Jesus is here. Yeah, and we're looking for the authors, and we found Jesus, and Jesus agreed to come to Vilnius, and we are very thankful for this. Well, because Jesus is going to talk about very important, extremely important thing in nowadays dentistry. It's corporate dentistry. I think it's a rising problem in all the countries across Europe. So we are looking forward to your presentation.
Thank you very much indeed. Providing dentistry is complex, is expensive, it's a very technologically demanding medical profession, and sometimes the effect of treatments are not very clear for patients either. What's the value of a single filling? Delivered early, the cost of prevention is always perceived many years down the line. So that generates sometimes distorted incentives. And I think sometimes corporate dentistry is used as a magic solution, as if it were something that is going to help, in some cases, governments or policymakers to compensate for a long-term lack of strategies in a way. So I want to discuss if that makes sense and under which circumstances it can make sense. So please understand it's a bit of a sensitive topic that has to be said from the beginning, because a little bit about myself. I am a dentist. I am also trained a health economist from the London School of Economics, there where Mr. Beveridge wrote the plan for a social state in the afterwar period, and that is my focus. I focus on well-being, not only dental, and besides that, I am a professional researcher, data scientist, and I generate technologies focused on dentistry for prevention. Besides that, I had the rare honor of working for the statutory German insurance fund on the side of the insurances, which is a relatively small team, but very relevant in terms of negotiating with other German partners, before leaving to create my own dental practice, consultancy firm, and software development company, where we advise and we accompany many different institutions, insurance funds, governments that have to undertake regulations in this field. However, I remained very engaged with research. I had the honor of co-authoring this very big exercise and effort that took several years to undertake with the European Observatory for Health Systems and Policies, in which we were able to determine in a very extensive report that there were three main core problems that are more or less extensive to the overall European healthcare system. And these are, for the most, that there is no comprehensive dental coverage in most of Europe, mainly because there is no universal health coverage in the area of dentistry, unlike in general medicine. That there are huge differences, secondly, as the access for dental care in many different regions, and importantly, the data is very scarce. We could not find good sources of data for that, because we cannot measure mainly the private sector in many cases, and most of dentistry in many countries is privatized. And thirdly, that there are many people excluded from accessing dental healthcare due to costs. And I think that's important before we start going through the data on it, that an increasing number of dental corporations entering the market sounds very attractive for many policymakers. This is something I have to now discuss from different angles. It sounds very enticing because it allows, with one very cheap method, a law of deregulation, to tackle what's perceived to be a problem that requires otherwise a lot of investment. So in order to provide and to pay for this dentistry, as the president of the European Council has mentioned before, you need to pay somehow, and if you don't pay out of pocket, you will pay through taxes. So raising taxes for paying for dental healthcare is and can be quite unpopular. And because of that, the regulation seems to be so appealing. Now, the point that I want to make now is that there is, so to say, a balance and counterbalance on this argument, and that's what I hope to show you in this presentation. So when faced with these three problems, most of policymakers can think, well, what do we need to do to be able to optimize and to help improve our oral healthcare system? We need more dentists, because also in Germany, in many other countries, so a significant portion of dentists will enter retirement age in the next years. We need more investment in infrastructure, which is increasingly more expensive because dental practices are small hospitals, are very, very expensive to run. We need to generate incentives so that dentists don't stick to pockets, so that they no longer decide to stay only in cities, but they also want to move to rural areas. And we need to reduce the costs of dentistry so that more people can access care. So, what can we do? We can deregularize the market, and we can allow corporate dentistry to happen. And this, as I mentioned before, makes sense from the perspective of simplicity of implementation of policies. So now let's try to argue from both sides. Whether this makes sense or not, there is a logic from one side, and there has to be a counter-argument for the other side. So from a dentist perspective, possibly dental chamber perspective as well, I don't want to overstep, but one can assume that these are the main criticisms that I've collected for the purpose of this presentation. Dentists normally conceive corporate dentistry as something that is profit optimizing, profit maximizing. They normally imagine that there are non-medical investors that constitute big dental chains that enter the market and compete with them because there is a lack of regulation. This lack of regulation constitutes, in some cases, unfair competition with smaller dental practices. And that, as a consequence, can also generate what's called a cream skimming or a downward push for quality, right? Which is understood as fast, low-quality treatments. So now I'm trying to play devil's advocate from a policy-making perspective of why this would make sense. Well, we can say, yes, profit maximizing, but this will bring capital for initial investment in the delivery of dental care. So I don't need to pay for a praxis. The investor will pay for it, and it will be providing services. And the non-medical investors with big dental chains, well, some people can agree to that, and they can say, well, this will generate a bigger economics of scale, and it will reduce costs, and it will increase access. So they're fine of going with that. And in terms of the regulation, one can see, well, we have more dentists competing for the same patients, now speaking in purely economical terms, which means lower costs, which can mean greater access. And the unfair competition with smaller dental practices can help to reduce the monopolic power to set prices that some dental practices have. The problem is with healthcare that it has to be delivered very close to where people live, because people cannot relocate, or rarely can relocate, to a different country or city to receive care. So that generates issues of what's understood in economics as monopolistic price setting, which is something that has to be avoided to secure access if it's going to be if it's going to be attempted through the market. And how about quality? Well, from a policymaker perspective, one could say they will normally allow a reduction of unnecessary care, and they will allow greater specialization. But I would like to then pose a question here. Who is right? Which argument is right in this case? So for that, I hope that we can start analyzing in greater detail the examples and the data that we do have, that we published in our recent report. First of all, we're speaking about the most prevalent condition in the EU and actually the most prevalent condition worldwide. Oral diseases are the #1 most prevalent condition affecting over half of the world population. As it was also mentioned before, is also the 3rd most costly one. So this is not a minor neglected area of healthcare. It's a proper failure of policy, I would argue. And when one considers that the access of care for this condition that is so prevalent is so different among European countries, one can see that there are certain patterns that start repeating themselves. So because it's not very easy to see here, I would like to just focus your attention on the following. Here we have the expenditure per capita in blue in 2008 by all these EU countries. And here we have in orange the expenditure per capita in 2019, almost 10 years later. We see that on top of the graph, we have Germany that has an increase of per capita expenditure, followed by Switzerland that has a completely type of system. And we see on the bottom of the table some of the countries that are still nevertheless showing the tendency that expenditure is growing with some interesting exceptions. The exceptions are Spain, that actually saw a reduction the last 10 years, and Greece. One could say with a possible correlation due to the financial crisis. And why this matters? It matters because the money that people have to pay out of pocket in each country to access different forms of healthcare shows that in the end they end up being more affected by it. This is money that could be spent in the case of a low-income household on sending children to a better school, on better food that can then lead to a lower risk of caries. So again, looking at this graph, the interesting part is here to see in this color, this is the out-of-pocket expenditure of the overall in medicine for dental care. And we see that there are some major outliers, and there are some countries that do not spend nowhere near as much, or that have decided to take, for example, a full coverage for all the out-of-pocket payments, which is supposed to maximize the access. The objective with these kind of policies is so that everyone that needs care receives it for free at the point of care. Beautiful idea, but very, very hard to implement, as we will see. With my colleagues of the observatory, we tried to create an imperfect map of coverage for which we had to define a number of basket of services that were then covered by some countries to create a typology. And with that, we were able to conclude that only a handful of countries have comprehensive coverage of dental services. We could not account, however, for how this was enforced. We can, however, determine that Germany, Austria, and Czech Republic do have a certainly very comprehensive basket of dental healthcare services when compared to other countries. Now, the interesting aspect is that these countries that have comprehensive coverage also have a significant investment in terms of the overall expenditure by the public sector. This means those countries that invested public money on dental care have better coverage or have achieved overall better coverage, at least in our report. So now, in order to go back to the topic of corporate dentistry, we need to look at the outliers. We will take the example of Germany, being the main, the country that has the broadest, most comprehensive form of coverage, which I will not cover in detail because we have the honor of having Professor Benz with us today, who will cover in detail these aspects of the German system. And we will take the other outlier, the example of Spain, to not take into account Greece due to the issues with the financial crisis. So what happened in Spain first? We see that when we compare both countries, the share paid by each country, Germany versus Spain, shows the biggest variability of all. So the majority of the services provided in Germany is pretty much coming out of the public system, whereas in Spain there is only a marginal investment on that. Not only that, but the type of pricing is different. It's not capitation, but it's basically a value-based system that rewards dentists on average with a price minimum, and it also caps the maximum, for the specific service of one specific, for the specific provision of one specific service. So this is a diagnostic-related group for the other economists in here, and it's a very, very rare form of paying for dental care, and very common in other areas of medicine, but very, very specific to the German system still, I would say. When you compare that with Spain, you have free pricing in Spain. That means that dentists can set their own prices, and that can have the positive effect of increasing access, but also the issue of making dentists compete on reducing costs, which is a never-ending scheme. You have that when it comes to the share of importance that public universities have, in Germany, most of dentists are still coming from public universities, whereas the private sector dominates the generation of new dentists in Spain. In order to run a dental practice in Germany, you need to have a contract with the local insurance association, whereas in Spain, in order to own a practice, you need to have that contract in Germany, and you don't have any form of restriction in Spain. Also, you don't need to even have an insurance for liability in Spain, which is very, very different when it comes to the comparison of and type of regulation that's very stringent also for the areas of prosthodontics. Prosthodontics are very severely audited in Germany, especially for public patients, and non-existent in Spain, and this will have more relevance potentially later. So why did Spain decide to go the path of liberalization, market deregulation, and increasing corporate dentistry? They had a chronic lack of dentists since the after Civil War period. They had an almost non-existent infrastructure of dental clinics. And importantly, they had no comprehensive statutory healthcare system for the ambulatory dental system. So it was a third-party payer system, and they did not have the institutions, mainly, that could facilitate cooperating or partnerships between private practices and the public. So the solution for that was, well, if we don't have dentists, let's create private universities and let's try to saturate the dental market. If we don't have infrastructure, let's just allow anyone to own and run a dental clinic. No clinic has to have any social responsibility insurance. And if we don't have the institutions, we will allow private equity firms to invest in dental clinics, and the prices will go down, and more people will get access, and we will let them set their own standards, which is complicated, as we will see. To this date, we don't have excellent data about the outcome in Spain, but we can know that around less than 10% of the population is now voluntarily insured in Spain, paying around a yearly prime of 240 euros per year per person. The market and the provision of dentistry in Spain is very atomized. We have many different small actors and practices, but we know that the amount of dental chains is growing. It's currently at 5%, and despite being only 5% of the total market, they place 30% of all implants that are high-value treatments. We also know that the top dental chain has 40% of the dental market and 28% of the total number of clinics. And we know that despite being a relatively minority number of clinics, they still have a very significant number of volume of production every year, having 1 billion over the 7 billion euros that Spanish individuals spend in dentistry every year. And what's the problem? Well, it's a story of a relative number of failures. So all these dental chains have filed for bankruptcy at one point or another over the last 6 to 7 years. And this has allowed for them being, so to say, in economic terms, too big to fail. So instead of being closed down, they were acquired by private equity firms that continue to run them, reform them, and there has been a number of merging and acquisitions that is generating increasingly what's a consolidation of the market. And some facts are worthy of being considered, because this type of deregulation has led that only one dental clinic that was formerly the biggest one in Europe led 350,000 patients with some form of prepaid treatments unfinished by the time they closed down. Not only that, but I spoke personally, and it has been reported that the strategies of these clinics have been to involve individuals that have lower income and higher need for dental care on predatory loans that are agreed by a third-party financing institution, and then they filed for bankruptcy and the treatment was never delivered. Increasingly concerning is as well that the quality management is now on the hands of private equity firms that in some cases are not even within the European jurisdiction, but they're rather established as a local chain of a for-profit organization that is in the US in some cases. Some of the founders of these big dental chains have even been imprisoned due to fiscal fraud. And the working conditions for dentists in these clinics are, for the most, very regrettable, and they involve significantly more work hours than a full-time in Northern Europe. So what we can conclude is that this set of policies did not change the fact that the market in Spain is still very atomized and you have many players. Nevertheless, you can see that it's rapidly consolidating and is due to a purposeful or wishful desire to not participate and not intervene in this market. This was the Spanish choice. Now, we're going to briefly talk about on Germany. I feel a bit that I may be overstepping in the presence of Professor Benz, but Germany also has had and has decided to take not a similar route, but they have decided to start a process of pseudo-liberalizing their dental healthcare system. Not only the dental healthcare system, but in coordination with the medical system, the ambulatory system. So for that, there is now a new form of public figure called, we're going to call them MVZ, Medizinische Versorgungszentrum, which are now institutions that can employ an unlimited number of dentists. They can also contract with the insurances themselves, and they pose some advantages. But the question is, why? Why did Germany, despite having such a successful system, why did they decide to go this way? So, it's a difficult question in itself. So when one starts analyzing it in greater detail, you see that the arguments are completely different to the issues that motivated Spanish policymakers. They basically said, well, younger dentists and an increasing amount of female dentists entering the dental workforce actually prefer to be employed over being dental entrepreneurs. Dental practices are becoming very high cost, they're a huge investment, they're also high revenue, but they pose a greater risk. There is a high cost for accessing the market, so we need to liberalize this. There are not enough incentives for practices to be created in rural regions. This was one key argument by German policymakers. So there where they're the most needed, we don't have enough of. And this will be improved if we let the market regulate itself. And then we also want to make dentistry more interdisciplinary, so we can allow now dentists to collaborate and cooperate with doctors. And of course, there was a bit of discussion about the unfair competition with small dental practices and if they bring a reduction on quality, right? So the logic was that these MVZs now can hire dentists, which was not allowed in Germany until very recently, compared to other countries. They said, well, MVZs are going to be treated specially. They can reinvest their own profit, which means that they will be able to grow much faster. And that means that as younger dentists can then be able to compete much faster. They said, well, we will have more money coming to serve those unmet populations, and this is how we're going to solve the issue in rural regions. And we will nevertheless make dentistry more interdisciplinary, and competition by providing dental care through these MVZs will not affect quality, because, this was the assumption by policymakers, because the owners of the chain will have to be dentists, they will have to respond with their assets for wrongdoing, and we're nevertheless going to audit them on equal terms. That was the assumption. So the point is that despite this very noble intention, one could say, and logical argumentation, there is some evidence that there is the known fact that investors have been able to manage some of these MVZs and use them for their purposes. The evidence that we have is that some of these institutions are actually putting financial pressure. They're billing the government more and more often, but we cannot be conclusive with this still. We can, however, already start seeing that some people are looking for dentists to then take the responsibility of an MVZ, which is something that explicitly by law is not fully contemplated, and it poses a risk of changing this dynamic and turning this law into long-term problematic. So we don't have evidence yet that the MVZs have brought the positive benefits that they were promised when they were created. We know that the number of MVZs has not been rising in rural areas. It has been mainly happening in cities. And we start seeing now early signs of concentration of dental practices in Germany in the hands of MVZs. So it is not my job to judge this policy, but the evidence that I can present to you at least suffices to understand what has happened in this case. So now we need to go back finally to the statistics that we reported in our book, where we see that the amount of adults that reported not having access to dental care due to financial reasons has been relatively high and is highly correlated with the income of a person. So the highest income a person has, this blue dot, the less likely this person is going to be to not be able to go to the dentist. And these people are the 20% lowest income individuals on a country. And you can see that the gap of access is very significant. So this bridge here between the rich and the poor is what these corporate dentist chains are supposed to achieve on their own without regulation. So goes the assumption. But we can see here that Germany, for example, does almost not have any distance between rich and poor accessing the market due to financial reasons. And we can see here that Spain, despite this very broad process of the regulation, has not achieved any positive impact that we can perceive in reducing this gap. Similarly, one could say that rich people, or those better off, are more likely to go to the dentist, right, than those that are worse off in different countries. And again, we have that in Germany. There is very little difference whether you are on the richest 20% or on the poorest 20% on going to the dentist last year, whereas this benefit in Spain is really not noticeable. So, to conclude, we can establish that corporate dentistry, of course, is going to turn dentistry into profit maximizing. One could say that is true, because chains are going to leave the market if they're not profitable. They don't have any oath or respect or due responsibility with patients, but to their shareholders. That has to be acknowledged. Is it true that there are non-medical investors, private equity firms creating big dental chains? It could be true, but it depends on the law that regulates dental healthcare. That allows and means that if one allows this to happen, it will happen, and it has to be considered as it has been the example previously. Is it true that these corporate chains exploit the lack of regulation of the dental market? It could be true. Again, if one has a regulated dental market that prevents bad incentives from happening, you're protecting not only patients, but you're also protecting dental provision and dentists themselves. What about unfair competition with smaller dental practices? That is not necessarily true if you have a regulated competition system in which you allow to set the prices on a value-based way, in which you can say, well, this is going to be the minimum that I can pay for this, and this is going to be the maximum. That allows to set, so to say, a more leveled play field. But this is only one example. Of course, I agree, different systems have different methods for this. However, the risk has to be taken into consideration. And what about quality? Well, quality is very complicated to measure. However, we have some evidence, including in Germany, where there have been independent reports in the state of Bavaria that have already raised some concerns about the possibility that excessive financial pressure can lead to overtreatment for patients and to excessive financial pressure. So, to conclude this presentation, I hope I'm on time, the thing we can say, or the points we can raise, at least when it comes to dentistry, is the following. At its best, allowing big corporations to invest in dental clinics has not shown to this date, and with the evidence that I have reviewed, to have a better market that compensates for the lack of access to dental healthcare. This is an impact that is not being seen not only in Europe, but it hasn't happened in other areas and in other countries. Famous examples such as the US come to mind. There is not a degree of deregulation that will, for its own, close the gap in dentistry, and at its worst, if one allows deregularization and market management without the appropriate auditing, also for quality and dental services, it can be very counterproductive for everyone involved in the dental healthcare system. And as a final remark, I would like to mention that we had last year, I had the honor of being the chairman at the World Health Summit with dental chief officers from South Africa, France, WHO, academia, the Lancet, private sector, and we were coming back to the topic of corporate dentistry because we all realized that the real issue was on access and coverage. If one can frame the question as a universal healthcare problem access, as we have done with medicine, we're more likely to be successful to not repeating the errors that have happened already in the past when it comes to over-liberalization and deregulation of the dental healthcare system market. That's all. Thank you very much, and if you want to stay in touch, that's my
Thank you very much for this exciting presentation, Jesus, and I'm sure we will have a fruitful discussion and interesting discussion in the afternoon. And now I must announce a coffee break for half an hour, and we will be back at 11 a.m. Thank you.
Thank you.
Fantastic.
Ladies and gentlemen, and now we will start to share experiences from different European countries, and we will start from Danish example, and I would like to introduce Dr. Pia Sloth Lisbier with her presentation about oral health care from the Danish perspective.
Thank you very much for inviting me to speak about the Danish oral healthcare system. I have been looking very much forward to visit your country and will enjoy a day of sightseeing tomorrow. I'm a dentist and have been that for many, many years. And if you notice the flag on the photo to the right, you can see it's the Danish flag, and we are very proud of it in Denmark. This is the house where we have our dental office and where we also live. Freddie has already told about our history, but I graduated in 1983 from the dental school in Aarhus, and the first 12 years I worked in Germany, then 5 years in public oral health care in Denmark, and then 20 years as an owner of a dental office. At the same time, I worked as a dental advisor for the region of South Denmark. Now I don't practice anymore. I work as part-time as a manager of the same dental office, and part-time as an expert advisor for the Agency of Patient Complaints in Denmark. The agency is a public authority covering all Denmark, and I will tell a little about that later. As you can hear, I know all sides of dentistry in Denmark, and I will tell a little about that now. The healthcare in Denmark is based on the national health system, security system, and so is also the oral healthcare. A large number of people also have a supplemental voluntary health insurance, about the half of the adult population, and more companies offers health insurance including dentistry as a benefit for their employees. The national government makes all the planning and decides on the overall budget. The regions and the municipalities are responsible for the detailed planning of delivering and makes the prevention programs for healthcare in general. Clinical guidelines are made by the Danish Health Authority, which also makes supervision and inspection of public and private healthcare providers. The healthcare in Denmark is strongly regulated by laws, consolidation acts, and guidance documents, and so also the oral healthcare, although a part of it is offered by private practice. To the left, you can see the overall regulations for healthcare, and to the right, the regulations specific for oral healthcare. And of course, we have all the other general regulations. I have counted them for you. There are 33 on the left and 35 to the right. The oral health care for children and young adults until the age of 18, recently altered to 19, and in 24 it will be altered to up to the age of 21, are provided by the municipalities in Denmark. And here there are no out-of-pocket payment. The public dental offices, often situated in every smaller city, are employing dentists, dental hygienists, and chairside assistants. The oral health care includes prevention of oral diseases, examination, treatments of oral diseases, and orthodontic treatments, if the malocclusion is severe enough to fall under the guidance document from the Danish Health Authority. The percentage of orthodontic treatments financed by the state by children and young adults in Denmark is about 25% of an age group. Young adults from the age of 16 also can choose treatment in private dental offices and still get a subsidy of 100%. The offices gets around 200 euros per capita and must provide the care for this amount of money. The public dental health system for children were established in 1972, and gradually all age groups between birth and 21 are integrated in the system. With the prevention, which in the first many years was given as group prevention, has resulted that we, for the group of 12-year-old children back in 77, only 5% were without caries, and now in 21, 84% is without caries. And therefore we now don't make any group prevention anymore, only individual prevention. The oral health care of adults is provided by private dental offices. There is a subsidy of approximately 40% and fixed prices for examinations, scalings, periodontal treatments, and extraction. We couldn't call it basic treatments. Dental fillings and root canal treatments, we have a subsidy of approximately 10% and free pricing. That means that the price of these treatments can be very different depending on which dental office you visit. Implant, prosthetics, orthodontics, and cosmetic treatments is 100% out-of-pocket payment and have free pricing too. We have a very liberal marketing and advertising rules, but also an obligation to declare and publish the practice structure and pricing on the market portal called Sundhed.dk, which means health.dk, owned by the government. We have special public offices who provide oral health care for physical or mental disabled persons who cannot visit a private dental office. Here there is a fixed out-of-pocket payment for approximately 250 euros per year. There is also special dental care program which give reimbursement higher than normal for welfare recipients and elderly people with a low income. A number of diseases with higher risk for all diseases gives access to a program which secure a maximum out-of-pocket payment for 250 euros per year These are rare congenital diseases which gives a higher risk for oral diseases, for example, dentinogenesis imperfecta, also damages after radiation against throat or mouth cancer, and damages after chemotherapy and Sjögren's syndrome. As summary, children and adults until 21 have free oral health care. Adults overall gets 15% reimbursement by the government. If you have a voluntary private insurance, they pay around 15%, the rest is out-of-pocket payment. In average, every adult visiting a dental office invests around 300 to 350 euros per year for oral health care. Note that is for people who are visiting a dental office. Regular users of dental offices is 80%, and the overall investment for children and young adults are 200 million euros. The adult out-of-pocket payment, 1.2 billion euros. State costs for adults, 200 million euros. And the special programs is approximately 80 million euros. Healthcare costs of GDP in Denmark is a little above average in Europe, which is 10%, but the percentage for dental healthcare costs of the overall costs is a little below. The European average is 5.1. For all inhabitants in Denmark, the overall costs is 250 euros, all including the people who doesn't visit a dental office. We have a situation in Denmark with not enough dentists, especially in the smaller cities. Therefore, we use both delegation and substitution. We have 75 dentists per 100,000 inhabitants. Our dental hygienists have their own authorization for examinations and periodontal treatments. In some dental offices, they make other treatments on delegation. Our chairside assistants don't have an authorization, but are educated and trained in supragingival scaling to take X-rays and impressions. They work under delegation, which means that the dentists have the responsibility and the duty to supervise. In fact, in Denmark, it is legal to delegate all kinds of treatments as long as we are taking the responsibility and makes written instructions. As I mentioned, I work 2 days a week for the Agency for Patient Complaints. The agency is a public authority which is managing complaints about treatments in the health system or complaints about treatment performed by a specific authorized treatment provider. We receive about over 9,000 complaints per year, from which 700 is about treatment in private and public dental offices. Here you can see the number of complaints in different groups in oral health care. It seems that we have very displeased patients in Denmark, but it doesn't seem as much complaints when you think about that we have around 8 million patient contacts per year. Here is how the complaints are settled. Of course, there are rejected complaints, complaints that are dropped and voluntary settlements, but when you take them all away, you can see for the cases which go through to the decision by the disciplinary board, you can see that it is almost 50-50 with cases where there's an expression of criticism to the dentist or dental office and cases with no expression of criticism. I've also been asked to tell about the recall system in Denmark. It is regulated by law, as always in Denmark, and based on a guideline by the National Health Authority. The health checks for adults is voluntary, but mandatory for children and young adults. There's a green track for patients with no active dental disease. They require examinations every 12 to 24 months. According to the Danish Dental Association, we expect this group to be 50%. There is a yellow track for patients with active dental diseases where the risk factors can be altered. They require examination and control examination frequently until there is no active dental disease anymore. Then they will follow the green track. And according to the Danish Dental Association, we expect this group to be about 30%. And the red track is for patients with risk factors such as diabetes, polypharmacia, patient with anti-resorptive treatment, and so on, where the risk factors cannot be altered, and we expect it to be at 20%. The average visits per year in Denmark is 0.8. We can't say anything about the overall cost for prevention of oral diseases because it is an integrated part of the examinations and control examinations. We have no group prevention programs, only individual prevention. The idea is that we don't use money and time on the healthy people. As a conclusion, we have a tax-funded national health care system strongly surveyed and controlled by management rules and authority, with a low degree of self-management by the profession. Until 2018, it was based on negotiation and dialogue and consensus with the profession. Now it's only ruled by law and by the government. We have a very high private financing of oral health care, especially if you need treatment. We have a mix of public and private dental offices. And then I will say thank you for your attention, and here's my email address if anybody wants to ask some questions and have more details.
Thank you very much, Pia, for wonderful presentation. And now we have a few minutes for questions and answers. So does anybody have any question? Yes, please.
I would have a general question, if it would be possible to receive on the read slides of the presentations. Because a lot of very much interesting information.
Yeah, yeah, of course we will share. And I have a question. Previously, it was mentioned that dental education in Denmark is not enough. I mean, you lack dentists. So what could be... I am dental educator as well, so I'm interested in this topic. So what is the reason that you, let's say, do not produce enough dentists you need? So do you feel that there's a lack of interest in young people in studying dentistry, or there's not enough financing from the governmental side?
It is so that all education is free in Denmark, and the government don't want to invest more.
So government feels that it's enough of dentists?
Yes.
The number is enough? Okay.
Maybe I can add a little bit
Yeah.
because I, for a long time, was the president of the Dental Association and was in close contact with our government. As you know, and you can see from the presentation, everything is very ruled in Denmark. The government takes control about everything. You can like it or you can dislike it, but it's how it is.
Yeah.
And you can also see that the Danish population is maybe the most happy people in the whole world. So we like to live in this country, although everything is controlled. And our national health authorities had made a prognostic planning for how many dentists we use for the future. So we have already, for now, have a plan, how many do we use in 2040. But they miscalculated. Also, as you heard in my presentation, you cannot expect that the dental disease and the way dentists work. So they have worked with this long-time planning, expecting that the disease would go to a lower level and that decreasing the number of dentists by replacing them by dental chairside assistants with the use of substitution, with the use of delegation, could solve the problem. What they didn't take into account was the changed work-life balance. The people want to work less hours. So this is about doing planning. One thing, they miscalculated the plan. We have in the Danish Dental Association been saying for 10 years, you are educating too less, you're educating too less. But as you know, educating dentists costs a lot of money. In Denmark, we calculate between 120,000 and 140,000 euro to educate a dentist. It's the most expensive education at all. So that's the reason why we have very fixed numbers saying we only educate 140 dentists a year, and we have done that for 20 years. As I also said in my presentation, there was a reason why I moved to Germany. We come from a time in the 80s, early 90s, where we have an overproduction. You see? So we first went down with the numbers, thought by making a planning we would have enough of them, also because we changed the way we work with dentistry, but it's not easy to calculate how much people you need. Also because the people were expecting that the prevention program would take so much over that it wasn't necessary to do treatment. And as I also said to you in my presentation, yes, of course we can achieve a lot about doing prevention. But you also have to understand doing small treatments will always be necessary. That's why I prefer to use the word, you cannot prevent dental disease, but you can control it. Okay?
Yes. Thanks for answering. And I have another question. Being pediatric dentist, I'm interested in pediatric dentistry, and you've mentioned in your presentation that it's mandatory annual dental checkups. So actually in Lithuania, we do have as well regulated by law that it's mandatory to go to dentist annually. However, if you don't go, so you live your happy or unhappy life, you see. So there's no measures for missing appointments. So what is the situation in your country?
In Denmark, we tell the social authority that the child is not coming to the examination, and then they will interfere.
And it is being treated like dental neglect, something like this,
Yes.
yeah?
Yes.
Yeah. Okay, that's what I thought.
The parents are required to have a meeting with the social overviewing system in the municipality, because this is a very severe situation if you neglect to do proper dental treatment for your children. As again, we have rules for everything. We are overviewing our citizens, so that's the way we do it in Denmark. Be happy about that.
So I see that you have another question, yeah?
No, I'd like to take part in the discussion because I'm a mother of two daughters. So one is 5 and another is 8 years old. And as Professor mentioned, we also have the annual checks. And I didn't thought there is a possibility not to take this checkup because then the kindergarten or the school says, okay, you do not have your report.
Well, actually, this certificate was introduced several years ago, but before, and still, if you don't go to kindergarten, for example, there's no control at all. So what you do at home and what is your dental status and in general health status. So that's my problem. And I would like to stress the attention of our Lithuanian politician that actually untreated dental disease should be legally considered as a dental neglect. Okay, this is my suggestion for changing the law. So, okay, thank you very much once again. And now we will have a presentation for our neighbor from Baltic states, professor, very well-known Professor Mare Sak, a board member of Estonian Dental Association, and we're looking forward to hear about your financing of oral health care in Estonia.
Thank you. As Vilma already said, I'm working as a full-time professor at the University of Tartu. I have been active in Estonian dental organizations for 40 years and having had lots of international contacts and cooperation as well. I'm learning the instrument. So just to start with some basic facts about Estonian dentistry. Currently we have active 1,346 dentists. Number of citizens is approximately 1.3 million. So dentist to population ratio is high, having the 6th place in the European list about coverage. So one dentist for 1,000 citizens approximately. Number of clinics is quite big, 529, and about almost half of them as in Tallinn. What concerns contracts with Estonian Health Insurance Fund, it's about 3 out of 4 dental institutions have contracts to use dental benefits, but 10% less have contracts for children dental care, which is kind of surprising also. DMFT for 12-year-olds has decreased to 2 in 2020. 20 years ago it was 2.4. GDP per citizen is about 23,600, and different from Lithuania, for example, we do not have community dentistry sector. We have 100% private dentistry, which means that fees for treatment are free for the period of independence since 1991. Total healthcare expenditure relative to gross domestic product is 6.73%, and this is also visible in Eurostat tables. Current healthcare expenditure per inhabitant is 1,800 by purchasing power standard. The dental care is covered by 10% of total healthcare expenditure. So it is much higher than European average today. It used to be 7% in 2003, so there is a noticeable increase in this area. Out-of-pocket payments by patients for dental care today are 70%. As we saw, it's about the same in many European areas. So this decrease compared to 2017 by 5% happened due to the establishment of the system of dental benefits for adults. Estonian Health Insurance Fund was established in 1992, and dental care for children is free of charge till the age of 19. Free dental care is still provided for 1 more year after the age of 19 if the treatment need was fixed before reaching this time limit. What is special treatment free of charge can be provided only by those dentists or dental institutions which have concluded the contract for financing medical treatment with this insurance fund. A dental checkup and treatment is recommended once a year, but it is not well regulated like you have it done in Denmark, so that's something to be done. In 2021, 59% of children visited a dentist, so where were lost those rest 40% is the question mark for us. Total cost for treatment is not limited. We do not have like some kind of fee per head. But what is limited is the number of cases for one dentist and the number of visits a year for one dentist. So it is kind of contract limitations, and but it can be negotiated if there is a need for additional financing. If we look at the proportions of as you said, treatment of neglect and preventive procedures. So this is where we can see that priority is treatment and operative dentistry compared to preventive aspects of dentistry. Orthodontic treatment for children is free of charge only in severe malocclusion cases. And here you can see the list. It is about 9 groups of diagnosis, which I consider to be severe. Increased overjet for more than 9 millimeters, angle-free 3rd class, anterior open bite more than 4 millimeters, delayed eruption of incisor or canine teeth, extensive hypodontia, increased and complete overbite with gingival or palatal trauma, lateral crossbite along 3 or more teeth on one side of the jaw, cleft lip and palate, and other congenital malformations, and dental anomaly in case of severe or moderate obstructive sleep apnea if other measures have not been effective. Dental care benefits for adults were introduced first time in 2017. It was initially 35 euros per year, but starting from January 1st of January 2018, it was increased to 40 euros, and it has been a promise that it will be increased even more. The trick is that it should form 50% of the medical bill presented to the patient, so there is 50% of self-responsibility for the patients out of 80 euros total, yeah? The medical invoice is prepared according to the fixed by health insurance fund price list. So about one visit a year is, let's say, covered by insurance for 40 euros. Other visits can be already billed according to the price list of the dental clinic. There is a group with a larger dental care benefit for 85 euros a year, and that is meant to be used for pregnant women, mothers with under 1-year-old children, people with partial or no capacity for work, and people with the age of over 63 years, and persons with increased need for dental care. Also unemployed people, if they have been unemployed for more than 2 months and they are registered at the unemployment insurance fund, can also have this kind of benefit. There is also left 15%, which is 15 euros out of 100 euros for self-responsibility. Once in every 3 years, health insurance fund will reimburse 260 euros for the cost of dentures to the patients receiving a pension for incapacity for work. Also old age pensioners, it is like older than 63 years, and people with reduced capacity for work. So these all fees are according to the dental clinic sales prices. And dental benefits can be used as only for primary treatments, and of course by the dentists having contract with insurance fund. What is remarkable is that patients can always check the remains of benefits on the web in e-health system. What are the primary services that are compensated? This is like first and repeated visit, like base cost of the visit, diagnostics, temporary and permanent restorations, tooth extractions, opening of an abscess, endodontic treatment, supra and subgingival removal of deposits, and local anesthesia. Of course, only according to the limited sum and using limit prices. There is also a possibility to use this larger benefit for the patients for whom dental need for dental care has arisen as a result of the provision of the following health services or diseases. That is surgical and or radiation therapy of tumors in the head and neck area, surgical treatment of lip, alveolar process and oral cavity, treatment of genetic and metabolic disorders that cause dental and maxillofacial anomalies, surgical treatment of trauma and inflammation in maxillofacial region, various medical procedures which can hurt teeth or cause some other damage, transplantation patients, first type of diabetes, and Sjögren's syndrome. There is also such a form of support to patients like lifelong dental treatment, which means if you once have this status, you can have treatment free of charge for all your life, and that is patients with psychological disturbances and physical disabilities, psychological disturbances like intellectuality disorders, dementia, autistic spectrum disorders, and some other psychological severe disorders. And physical causes like paralysis that affects both upper limbs, you cannot clean your teeth, or you have a disease of the central nervous system, movement disorders like Parkinsonism, generalized dystonia severe Down's disease, and congenital or acquired physical characteristic like absence of the limb or similar. This year, some other conditions were added, like patients who have been diagnosed with malignant tumor in the head and neck region, and those patients who have received radiation therapy or chemotherapy and who have received anti-resorptive therapy with biphosphonates or denosumab. And some hematological conditions like myeloma multiplex or malignant tumor of lymphatic and hematopoietic tissue. Yeah, and we have a special code for those patients. Once you have received, it's for lifetime. Describing availability of dental care for adults, I bring you data presented by Kantar Emor, which is a leading data insight and business consulting company in Estonia, and is providing studies for about 100 countries around the world. But this is based on questionnaires presented to citizens. And if we look at this, it looks brilliant that there are no dental or oral health problems in almost 95% of citizens. And only 5% complained that the treatment was not available. What was surprising, 10% of the population did not know that child dental care is free of charge. 58% visited dentist once a year or more, and 87 were satisfied with dental services. From those who did not visit once a year, a dentist, they commented that there was no treatment need, approximately 40%, and economic reasons like 32%. But when our institute carried out a clinical study, it became apparent that treatment need was not so nice as by this obtained data by questionnaire from citizens. The treatment was not needed, only about 20 to 30% of cases from those patients who came to examination. It will be soon published in international journals. We have seen some risks with this fixed price list by Health Insurance Fund, and that is that it can reduce the time to perform the procedure, that those institutions are inclined to use cheap equipment, materials, instruments. Focus is on symptomatic treatment because it's more expensive. They prioritize restorative instead of prevention, as we saw from the former graphics. It can reduce also costs for investments and quality. So this is something which can be a threat from a fixed price list, but currently we have to use those limited prices only in cases when health insurance co-funding is the case. We also have a private dental insurance introduced in Estonia, but to be honest, it has not become very popular. Concerning prevention programs carried out in Estonia, something to remember is that these programs, it is not a national program like you are planning to introduce or is in most of the countries who have good oral health status. It is project-based, and it's paid like this starting from 2009. It is approximately 300,000 per year, and it's used mostly to finance oral health education in children and also now in adults. We have a very good database and source of information about oral health on website, SuKool, which means Oral Health School, and this is designed and constructed, funded by Health Insurance Fund. All of the preventive measures can be coded in for the Health Insurance Fund. They are paid in full amount, so that is not an obstacle. It's the understanding and kind of prioritizing by every individual dentist. And lots of projects, as I said, have been carried out, but it includes for the last, let's say, 2 or 3 years, Oral Health School fight, so oral buggies. It's a very fun program for kindergartens where lots of groups, 412 groups participated, including 8,000 children. But as you saw earlier, we have children in various age groups, about 240,000. Such a very popular song was created by this fund. It's a Brush Your Teeth song for children. It's also in English, and children also are very fond of it. A Smile Award by FDI was given in 2019 to Estonian Dental Association for the project's Children Dental Health. So spread of knowledge is through this webpage very good, and also there are aid materials for lecturers and all healthcare workers who want to do promotion of oral health in certain groups. And now also Oral Health University has started, which means creating podcasts, articles, and so on for adult people. This year, a fun, attractive, and educational toothbrushing application was designed, and it has, if it's downloaded and followed, the award will be a visit to a dentist and to get the toothpaste and maybe something else. And to finish, as it has been a popular topic in our media last weeks, I shall present you average gross salaries in Estonian dental sector. It's for the 2021 now. So average basic salary for doctors in dentistry sector was almost 1.5 years ago. Now it's March 2021. It was 4,252 for general practitioners, 3,900 for prosthodontists, about 5,000, oral maxillofacial surgeons, 6,177, orthodontists more than 9,000. Annual increase was in 2021 versus 2020, 6%, but this year we already have fixed increase in salaries for 17%. For comparison, average salary for medical doctors is about the same size like in dentistry, a little less than 4,000, and Estonian average gross salary for citizens 1,473. And there is similar increase compared to dental sector. What is nice about it is that this increase in salaries has stopped migration towards Finland from Estonia. And me as a teacher at university, I'm especially happy because we don't have to educate for a more for a better economic country dentists nowadays. So that's about to finish my presentation, and I'm waiting for questions or remarks.
Thank you very much for presentation. Now we do have few minutes for question answer session, and I would like to stress that all the attendees are welcome to ask questions if you have any. So, okay, Brigitta, and then.
Thank you, dear professor. What was very interesting because, you know, Lithuania and Estonia are much more comparable countries than, for example, Lithuania and Denmark. But it was very interesting. I have two questions. What is the reason of success of growth of the early checkups from 37% in 2015 to 58% in 2020? As I understand it, we talk about the grown-ups, about not about children. Is this because of Sulika of this program? And another question: that salaries of the doctors, dentists, and assistants and so on before taxes. Yes, the numbers are before taxes.
This is like brutto salary.
Yeah, before.
Yeah, yeah. This is brutto salary. But the, let's say, rate of visitation has increased, I think, due to our good educational projects and work done by Estonian Dental Association, because funding is coming from health insurance fund, but actually our colleagues are carrying this load of this work, and this web page, and I mean all of those printed matters and podcasts and everything is doing a good job here. And this is somehow a part of image for citizens to have a healthy and nice smile. So that is also one reason why people tend to visit the dentist more frequently.
Thank you. We have another question, Morgana.
Thank you so much for your presentation. My question is around the same topic. Well, in Lithuania, we have had this problem for many, many years that we invest in something, but then we forget to evaluate the results. So when you were presenting and talking now about different tools you use to educate adults and also children and the app development and other measures, have you evaluated the actual results each of this measure produced? And, do you know which one of them was the most effective, less effective, and so on up to this day? Or are you still where we are with this thing? Because now you're sharing your opinion, like saying you think the education helped, but do you have data for that?
No, sorry to say, no. We have not evaluated, each of those measures carried out during these many years. But I think, though not always so realistic, these counter-remor questionnaires, they are carried out with a certain time difference, and that it reflects something, at least attitude towards treatment, the importance of oral health as part of general health. And I think that treatment need has also increased due to better economic situation during those last 5 years. Piret, will you add something?
I just wanted to add a little bit about this children prevention program. And this is a project. And this I think, has been years run by the basis of projects. The problem with projects is that project is starting and then it is ending. And there will be another project. And what I think we lack this kind of strategy, which is for long term and continuity, and this kind of long term strategy for oral health. Because we have had this we had a project years ago. It was to implement the oral passport. So every mother, when the child was born, received a passport where it was mentioned where it is basically like almost mandatory to be filled by dentist. That the patient and the mother knows that then I need to go, and then the child goes to school, he has this passport, it needs to be filled. It's not that everybody sees that we have not been. But what happened, this project ended. Sigfond was not anymore interested about it. Nobody asked what was the result. We wanted it to be more mandatory, really to continue it. At the end, we had in our association Zeller the boxes of this because nobody wanted them anymore, and even the hospitals were not interested anymore. So I think that's this reason why we don't have this kind of feedback. What would be really important. What we know that this song was very popular. We can see how much it was watched. The children know it from the head, they sing it.
It's millions.
It's really millions, and this is popular. This app is growing, so it is up to dentists now to all the time really promote this kind of tools to be used, and this part of it. And what Professor could not mention is that the part of the private practices who are not in a contract, these prevention issues are totally missing in the statistics, because this is not statistically as it is from the Sigfond, which is very clear. Sorry about so long.
Thank you. I would like to briefly add a bit in terms of policy evaluation, and I think it's a particularly relevant topic. I would say pretty much after this hours discussing oral healthcare, I would say pretty much it's the elephant in the room, that we do not have data enough to evaluate appropriately the effectiveness of different policies, and that is a very significant problem to be able to determine the effectiveness and also the cost effectiveness, because a very interesting aspect is that one should be able to determine which intervention is the most effective. So let's imagine that we have two options. We can invest on healthcare promotion and promoting young people learning how to look after their oral health, or we can open schools. And if health literacy by its own is capable of reducing the incidence of caries, well, one could say, or policymakers could say, we're better off opening schools instead of investing in oral health promotion. But the lack of cooperation, even at the European level, has been very remarkable. And I'm allowing myself to say this because I've worked with the European Observatory, yet I am not an employee of the European Observatory. I'm an external researcher from an independent university that cooperates with them for dental matters, because they don't have the capacity themselves. So we have very sophisticated data, or much more sophisticated, much more cooperation in terms of general medicine, yet that capacity building still is missing in our area. And part of that is also because we don't have good structured public data, because most of the data lays in private organizations, which are highly atomized small dental practices that do not share effectiveness. So that on its own is something that adds complexity for development of any policy in the dental public health arena. And it's an important point to be contemplated if one wants to go forward over time.
Okay, so very last question, please.
You mentioned in your presentation about fixed prices, that you don't like them. And you point out two interesting things, that the children are less popular, let's say, for the state funding than the adults. So what is a price, and is counted by person, by year, by procedure, or how it's organized? Thank you.
This fixed price list is a result of accounting done by Health Insurance Fund, and they have also asked for advice and input from the Dental Association. But dentists, it is not really taking into account all costs of treatments. And that's why, as for children, you have to do all treatments throughout the year, like with those fixed prices. And many times it takes more time for a child to communicate, to get the procedure done. And it is not covering, equally compared to adults, this, let's say, hourly income rate. And for adults, it is just one sitting a year. It's one visit when this 40 euros is used. And there is a psychological effect. This level of number of contracts increased during COVID period because dentists were afraid what will happen on the labor market, how much treatment is needed, what people can afford if they are, unemployed or whatever, because of many institutions were closed. So it has such effects on this, and lots of bureaucracy, which is coming along, which needs more workforce to manage all of those conditions which are set by Health Insurance Fund. And that is kind of limiting this number of contracts because, as I said, all dentistry is private-based in Estonia. State has not funded any euros in dentistry, and they want to, in a way, turn private practice into community dentistry institution. So that is some kind of conflict of interests, between dental practitioners and actually state-managed health insurance fund, which is tax-paid by citizens' foundation.
Actually, it's a very, very actual topic, and we will come back in the afternoon to the same topic. Well, please don't forget your topic and your question, but we need to stick to our timetable. And now I would like to invite the president of German Dental Chamber, Professor Christoph Benz, to present oral health care financing system in Germany.
Thank you very much. It's a great honor and pleasure for me to be here, and thank you for this Congress organization, and thank you for the invitation. I have to apologize a little bit for my English. I lived as a child in Canada, but my English became more and more rusty, so words are missing. I hope you will understand at least a little bit of what I'm talking about. So. My agenda should be 2 points. One being figures and facts about Germany, and the other one very strange situation. Dentistry is changing quite a lot, going from mechanical treatment to prevention and many other things in Germany. So the dentist in 10 years will be quite a different person than it was when I studied 39 years ago. So, next slide. Figures and facts. We have 72,000 dentists in Germany, and working dentists. And this number is perfect. We analyzed this in 2009, taking into account all relevant aspects. And this number would be perfect if the distribution of these dentists over the space of Germany would be correct. But because of these private equity idiots, that employ people in the big cities, we have the number of dentists in the rural areas is too small now, and we have to change this. And as this wonderful presentation told us, these MVZs don't go to the rural areas. They promised it to the politics that they were working in the rural areas, but they don't. So the problem is distribution, not numbers. And yes, there is a trend to female dentistry. This number of students is 2/3 women, 1/3 men. I think it's not because of the lacking interest of men in dentistry. It's just because of this more or less stupid system to have good grades in school as a situation that you can study medicine and dentistry. It's stupid. There is no reason, but the people in the universities love this because students with good grades are always calm and don't talk against something and so on. And the situation in the offices is not quite there, but of course it's changing too. We have 66, 2/3 of the dentists are working in their own surgery, self-employed. 70% are in training. In Germany, you need 2 years of training in order to be able to work for a special insurance system. And almost every dentist works with this insurance system, so they all need this training, 2 years, and afterwards they can decide whether they go to their own surgery or stay employed. And this employment is possible since 2015, and it was quite a stupid idea to make this possible. In Austria, for instance, it's not possible to be employed for a longer time in dentistry. I think the DNA of dentistry is not employment, it's self-employment. The average age of dentists in Germany is around 50. So we will lose some of the old guys and get some of the new women. And I hope dentistry does not change too much in this course. We have two insurance systems. One is a statutory or public or whatever you want to call it, health insurance system. It covers most of the Germans. 89% of the Germans belong to the statutory health insurance systems, and the other system is a private health insurance system, which does a very strange trick. It's cheaper for the younger person to pay those fees, and it delivers more. Quite strange trick. Doctors, medical doctors love private patients more than patients belonging to the statutory system, which is not true for dentistry, because we have a special situation. We like both groups of patients very much. And this is the situation of earnings of the average dentist. He gets 53% of statutory out of the statutory health insurance system, and he gets 24% more from these patients because for treatments like ceramic crowns or implants and so on, the statutory health system does not pay. So if you want this as a patient, you get an additional bill from the dentist, and then you have to pay it out of your own pocket, or you have an additional insurance, which is possible too. And the private patients pay 23%. So you see, the private patient still is very interesting because it pays twice as much as the patient from the statutory system, because the number is so small. Only 11% of the patients are belonging to this private insurance system. Maybe one additional point, a large portion of this 24% out of the pocket is prevention now, because patients, 84% of German patients go at least once a year to professional cleaning of their teeth, which they have to pay for themselves. And I think it only works because the patients pay for themselves. The general medicine shows us that prevention does not work if it's for free. This is a situation we cannot change. It's in our hearts and souls. We are lazy. Okay. Dentistry is only 0.8% of the gross domestic product. Medicine is 12%, much more overall health. So we are very little apart, about $453 per person. Medicine is about $7,000 per person and year. Our share in this statutory health insurance system is declining, not in absolute figures, but in the portion, in the share. It's declined from 1980 to today about 58%. And most of the reason for this is professional cleaning is prevention. This is the reason for this, and the reduction shows in many figures. I can show you in the following. Dentistry is changing. When I studied in 1983, dentistry was crowns, fillings, prosthodontics, and no prevention. Prevention was almost nothing. In 1983, it's crazy. And in the 1970s and 1980s was the El Dorado of the German dentists. I'd like to call it the heavy metal dentistry, because we took tons of gold and amalgam in the mouths of our population. And what was the outcome for the oral health? Nothing. We were in the ranking of the countries in the world at the bottom. We spent most money and got less. So a very stupid situation. But the dentists loved it. That was a time when they bought the Porsches and so on. It was wonderful. And the helicopters. And we have some of the old guys who are still dreaming of these years. In 1989, we performed the first nationwide oral health study, and I didn't develop it, I don't work for it, so I may say it's the best study in the world. It's not conducting telephone interviews, it's clinical investigations, it's representative for all parts of Germany, of all, for the complete population, so it's one of the best studies in the world. And and it was following studies in 1991, because after the reunion with the German Democratic Republic, we wanted to see how things were there. And then in 1997, 2005, 2015, 2024 is under work. And this is the publication for the fifth phase, and this means the V means 5 in Roman numbers, I think. And it's a very big book. It's perfect. You asked scientific evidence. This is not opinion. This is science. But of course, a cross-sectional study is not able to answer all our questions. Of course not. And with the first study, we saw that we were at the bottom of the ranking in the world concerning oral health, and this gave the dentists a kick in the ass. They moved in the direction of prevention, and we did all this by ourselves. There was no politician saying you have to do this and this and this. We started with the children, and nowadays we even have prevention for people in special care, old age people. So prevention everywhere. The statutory system pays until 18 and pays again if you have a degree of special care that you need, of inability. But everything in between has to pay, the patient has to pay for himself. And the numbers show the effect. In 1991, this graph starts, and it shows for 3 treatment classes the development now. For all the patients in the statutory system, meaning 89% of Germans. And this is the reduction of fillings. Today we make only half of the fillings we made in 1991, not because we became blind and not able to see caries anymore. It is just because they are not necessary anymore. It's a reduction of 52%. This is the reduction of root canal treatments, 21%. This is a reduction of tooth extractions, 36%, which means a tooth that is not missing must not be replaced. It's very easy. And this you see the speeding up of this, and you can give a underlie a mathematical model, and it shows that between 2040 and 2050, these figures will reach 0. Which of course will not happen, but it's speeding up, as you can see. So prevention works, and it works in prosthodontics too. There is quite a good study looking at the years 2012 to 2017, and Germany is one of the most aging countries in the world. There is only Japan more a number of old age people, and nevertheless we have a reduction of prosthodontics of 10%. And this figure, it's crazy. If you follow this over the years with a mathematical model, it reaches 0 between 2040 and 2050. I will not live there anymore, so very good. No more mechanical treatment anymore. So the situation we have in Germany is diversification. This is showing one of the most modern German inventions. No, not just a joke. This is an old age drill. We grew up with a drill in our hands, and it's very difficult for us to think anything else than drilling. But we have to switch, and this is not for just employing more girls who clean teeth. This is a job for us because we have the overlook. All the health aspects are necessary. This is a very old idea. 100 years ago, when the dental hygienist name was developed, no dentists wanted to think about cleaning teeth. So this guy, Alfred Phones, he just said, we have cleaning women for the floor, so we take cleaning women for the teeth. Just crazy old age idea. We have to come over this in the future. And we have other aspects. We have this aligner dentistry, very interesting possibilities opening up there. We have this large number of persons that cannot care for themselves anymore. 5 million people in Germany already. 100 persons per dental office in Germany. It's a very big number. We have these persons that are too heavy for our chairs. There is almost 1 million Germans weighing 200 kilograms and more, and you cannot place them on any chair. And the English coined a name for this, bariatric dentistry. And nutrition is something you can work, sports dentistry, sleeping dentistry, and there's so much diversification, but drilling is less and less necessary. And this is very important for me. The DNA of dentistry is small, patient-orientated, very individual, not in any industrial level, self-employed. This is an office, a rural surgery in Bavaria, only 4 people. The guy is the dentist, but it could be a girl too, and 3 employees, and they are having fun, as we see. And this is enough for 80 to 90% of every modern dentistry. Freddie is my president of the hearts of the CED, but there's one point I disagree. Dentistry is not too expensive for a guy like him, because the most expensive thing you can buy in dentistry is a computer 3D radiology system. And it's not so expensive, 80,000 euros, and it's yours. Every office can pay this if they need it. So we don't need any private equity whatsoever. It's unnecessary. And this is not the dentistry of the future. This is a industrial level. Maybe in the 70s and 80s, when we had our heavy metal dentistry working with tons of golds, then it would have been perfect. But now it's diversification, individuality, and so on. Why do we need these industries? So it's not necessary. And there is, and the boys want big things. It's always the same, and they talk to private equity and say, "Give me such a big office." But the girls have a problem too. They like to stay their whole life on the child's seat in the car and don't want to steer for themselves, which is crazy. Why? It's the easiest way to make a startup is a dental office. Almost no risks. So, and if you look at this small team, so it's not such you don't have to be the biggest entrepreneur in the world to manage such a small team. It's fun. So, where's the problem? Why do they always want to work for boys in big offices? It's crazy. Do it for yourself. And this is my conclusion. Prevention is the future of dentistry, and it will not change anymore. It will not change. Maybe if we get this atomic war whatsoever, then things might change. But in all other cases, prevention is the future. Nothing else will happen. And keep it small and simple. All these successes I showed to you concerning prevention were done in the small offices, not in the big factories. So keep it small and simple. And don't listen to greedy investors. They always tell you, I give you more and more and more. And when you finally look, and this is evidence and not just opinion, they deliver nothing. They just deliver money, and they don't even invest it in Germany. They bring it to some islands where they don't have to pay taxes. The university in Bochum just analyzed this, and they showed you they are carrying bags of money to wherever these islands are, these pirate islands. And self-employment is the secret of success. This is the secret of success. If you put it in, I worked at a university, and I always say this is the earliest form of a AMV set of a dental chain or whatsoever. And what was the idea we had when we were at the university? 9 to 5. Don't work too much. Working too much won't make you happy. When you're in your office, you're just much more interested in your patients. And of course, I don't talk about universities. I just talk about universities in Germany. And therefore, I think this is the secret of success. And changing this kills success. That's my opinion. Thank you very much.
Thank you very much, Professor, for such inspiring educational speech for young dentists. Yeah. I hope that Lithuanian dentists were also listening to your speech and will get some lessons. So, and I would like to ask a question, if you are still with us. I forgot my question.
Then I can ask. To be precise, I feel like in the TED Talks right now. It was really inspirational. But may I ask you, you mentioned so much give attention for self-employment. But at the same time, we just heard in the morning session that the governments are much interested in those chain groups. So do you see any Do you know the reason why? Or do you have some insights on that? Because it's very important. Everybody understood the big chain one or another day will bring down the quality, make cheap prices, but then the complaints, and then it's not good for the market and not for the people.
It's a very good question. In Germany, we have the situation with the hospitals, always problematic. They don't have enough money during the maybe gas crisis. Now, some of them will go bankrupt. It's always tight with the money, always problematic. And now these stupid politicians try to take this system in the outpatient system. Why? You can only speculate. Maybe employees are easier to handle. Maybe they don't give you contra words. Maybe. I don't know, but you won't get success. You will be. You need to fix the outpatient system like you have to fix the hospitals now. It's just more work. It's not the better way.
You know, I've been following these trends in Europe a long time. So what comes into my mind, why they want it? You mentioned this deregulation. There was happening this deregulation, or they wanted to investigate, are these professionals, so-called greedy professionals, maybe they are over-regulated. Maybe we can reduce the cost if we could implement different systems to employ somebody who is not educated as much. So this kind of process, I think, starts from there. And they have these kind of ideas, discussing with some of them, that if there is more free market, then all these prices go down and it's more simple. But we, as a dentist, we know it is not. And it is like they take patients as a clients already. I think this trend was changing totally medicine when this was implemented. That the patients are also like clients, but health was why it was not in a service director, because it is so different service. And I think it was Florian who said that you will see there will be maybe one day another directive which regulates our work, because they want to somehow deregulate and regulate these things. And I think the goal is that they think that if there's a bigger system, somehow some things are deregulated, and that is taking down the price. But it's not so. And I think that if there are qualified dentists who have ethics responsibility, they do it what is necessary for the patient. Because all service, what investor wants to get profit, he wants to get his money. And then when they rule the clinic, then it is to make more money. It's not about what patients are needing. But health services are by the needs of the patients and not by the needs of investors. But I think that there is a big gap in between on this understanding. They think more and more that, okay, this is like another service. We can just do it this way and have a more free market. I see it in Estonia. We have a very liberal country. They want to liberalize everything, and everything should be, by responsibility and of the patients or the professionals who are doing it. And even if you give your work to some undereducated person, you are taking, like you said, maybe in Denmark it is more like this. But I think that if it concerns health, the quality and the patient safety needs to be guaranteed. And this is something I think maybe we need to stress on this, but the meaning why they are in favor or have been, it's more to reduce the cost.
If I could add, we could now open up a discussion, then we will run out and we will have no lunch. I will not do that, but I hope we can come back to that in the afternoon, because as you heard me saying in the morning, please be careful and don't think the system that you have in your own country is the only system working. There are a lot of systems out there that works very pretty. So you have to be open-minded. It's not only about the system, it's also how the system is done and the people working in the system. So I really would like to have a wonderful discussion about that in the afternoon. And I will really like to tell you about why I think dental team is the future, also seen from the side of the dentist. But the question was here, why do the governments, why do they want this corporate model? We were at that time, where I was the president in Denmark, in close dialogue and connection with our government. I went there so often that I was allowed to go in and out without the security procedure for normal, because they said, Freddie, you've been here so often, you know the procedure. So why did they do that in Denmark? I think it's the same reasons everywhere else. And as you also heard from Pier's presentation, we are now ruled by law. What do a politician want to achieve? There's one goal he always wants: budget control. If you can give him budget control, you can have everything. But if you can't give him budget control, you can have nothing. And why? Because the cost that we face in health will raise that way in the future. And they have to find the money somewhere. So of course they look for possibilities where they can get the services that they want cheaper. So we have to change our mind. That's what I think. Shall we give them budget control? Maybe, because they need it. I'm not saying you should give them everything they ask for, but you have to move a little bit in that direction. And as you heard from Pier's presentation, and then I will stop, we have a totally public dentistry for children in Denmark. And this is not a competition. It is not a comparison who wins. Go to the literature. Which system wins every time when we are talking about children? Denmark will be, when not number one, then 2 or 3. What do we have in this system? Totally budget control. We have always had this, was a part of that. It's employed people, so only employed people. So self-employment, I don't believe it's the only right way to do dentistry. Sorry for that, because look at the figures in Denmark. It works with employed people. And then it works because we evaluate our system every year. We had a central register where we report for every year for the children, and we have done that since 1972. So we know everything. We know what works. We know if we do something, we can read it in the papers a couple of years later. So, but again, I'm happy to have a full discussion because I know a little bit about how to do the industry.
What happened to Denmark? In earlier years, you were gruesome Viking warriors, and now you're obeying law.
Okay, you can also read features and see that it works.
So I got my question back, but I will spare it for afternoon session. So thank you very much for nice presentation, nice discussion. And now we're going to have a lunch break, and we are coming back 1:30.
Lunch is in the hotel nearby, round the corner, Novotel, on the second.
So, dear colleagues, welcome back after break. And I must announce that unfortunately we do not have representative from Latvian Dental Association. During the sickness, she wasn't able to attend. So we are going directly to Lithuanian representative, Bronius Einars, a board member of Lithuanian Dental Chamber, and he will present the accessibility and financing issues of oral health services in Lithuania.
Thank you so much. I think I need to start from very nice and important statement. Typically the chambers and the ministries of health are not in very good connection. Typically they are very good connection, but some misunderstandings always happens. That's why my presentation in a way will be a bit similar what the Vice Minister present, and some numbers you will see there too. But what I want to point out, we are looking at the same numbers, but totally from different perspective. And I think that's why we are here to discuss about the accessibility, to discuss about the financing. And some perceptions from both sides are of course various, but I'm sure that after this discussion, after continuous discussions afterwards, it will be better and better, and we finally find the best outcome for our patients. So when we talk about the accessibility of the services, I'm sure that Estonia just mentioned previously about very high number of doctor dentists by 10,000 population. But if you look at the latest numbers in the year 2020, so we have 11.4 doctor dentists for 10,000 population, which is, if not the highest number, but nearly the highest number, not only in European Union, but also worldwide. It means that there are so huge potential that the accessibility of those services in Lithuania are most probably really ready to be served and possible. At the same time, of course, we need to talk about our team. And here again, we have some difficulties because here I'm presenting the numbers, what we have in our dental chamber, what members or what kind of members we have. And as you see, we are not only have doctor dentists and doctor dentist specialists, but also dental technicians, oral hygienist assistants and oral hygienist assistants, and other who has double license. And this is very important. I do believe that it's added value when we look at any kind of problem or a decision-making process from various parts of the dental market. So if we talking about the dentistry, typically in Lithuania we talk about the full spectrum of services. Either it's dentures, how to do dentures, either to do the standards for the dental assistants. And I'm sure that we will continuously talk about some peculiarities, I would say, because in Lithuania, our dental assistants, the nurses or whatever we call them, they are specially trained, they are specially educated, they have a college level or university level education. And in some countries, I know that there are some freedom on that, and you can choose and train the assistant on your own, and you have nearly no regulation for them. So as you see, 3,605 members out of 4,200, which is officially registered in Lithuania, are members of our dental chamber. And we have 983 dental technicians, more than 1,000 oral hygienists, and assistant 1,531. Actually, official statistics differs, but maybe it's because we have too many responsible entities who give this information into the market. And if we look at the Hygiena Institute, who combines all the information from Lithuania, they propose, they give numbers, those who they know, and they are missing about 20% of the information from the market. But if we talk about the Ministry of Health, or if we talk about the licensing institution, who nowadays, already 2 years also licensing all oral specialists, including dentists, so they're also giving different numbers. So here I propose giving the numbers only from the market or from our members. in year 2020, we lost some function of licensing as an institution, and it was delegated back to government institution. However, the missing part is very low. The numbers are very low, and even more, we are attracted, or we attract so many institutions or the healthcare institutions to become part of our organization. That's why the numbers in general altogether, it's more than 8,500 people altogether. Just to know, the recent surveys of state institutions shows up that in the market nowadays, for 3 million, less than 3 million population, we have 12,000 people altogether. It's including not only the medical stuff, but also the supporting stuff, the registration and welcoming and others. We concentrate our this presentation on naming and talking about the primary oral health care. Why? It's only, let's say, half or 55% of all financial support or the state-supported services, because we have some clear understanding why it's so important for us, for Lithuanians, for our patients. So until 2018, we have two types of dentists. So they were dentist and dentist specialist, which means the orthodontic, children doctor, endodontic, oral surgeon, and etc. After year 2018, the dentist or general dentist was divided in two categories, which means the primary healthcare dentist and the dentist general practitioner. And what it means, it gives a really impact when we're talking about the accessibility of the services for state-funded services. So primary oral healthcare, of course, you know, it's non-specialized primary oral dental healthcare services, which includes the treatment of dental caries, treatment of pulpitis, treatment of some periodontitis, and so on. So I will not go deep in this, but just to have a general view on what kind of services we have. Okay. What is also important, we need to talk about the service providers. As per now, we have more than 2,200 institutions, dental practice and dental technician labors, who are providing general dental services. But not everyone is allowed to serve the state-funded services, and we have, I would say, a bit strange regulation when we are totally dependent on family doctor. The family doctor is a must if you want to provide the state-funded services. Even if within a team is a psychological, psychological services providers, specialists included, they have an ability and possibility to decide themselves and to make a contract with patient. We as a dentists or the dental institutions, we have no such right. And that's why one of the thoughts why to initiate such wide discussion together with our colleagues from all neighboring countries is to really learn how it is organized in other countries. Even if we know that in Germany, in Denmark, in Estonia, in Latvia, in most of the countries, it's totally divided. In Lithuania, we are much interconnected, and it's not the only case. The case is also that we are not only dependent on the state contract, but sometimes the family doctor offices, they use this possibility sometimes to put us aside, even if we already provided some services for some period. It means it's not only the free of charge services for population, which is very cheap, which later you will learn, but also not getting even the payment for what you already done. So nowadays, maybe the numbers are not exact as much because it's numbers from 2020. So we have 330 organizations, institutions, divided by half, state-funded and private, who are able to have a contract with the state and provide this oral health services for general population. So when we look at this picture, I would say it's quite clearly shows how it works. So the left side, you can see it's a state-funded services. So only 24% of all patients are getting services there by state-funded services. Only 17% of adults, 18 plus, it means mainly people in the elderly age or handicapped who are getting the services in state-funded in this part. We have, as I already told, 16% of service providers, and only 55% of children are getting the service funded by state. What it means? It means that 100% of money is going to this 16 or 20% of the institutions, because the law said very clearly, every patient must be registered with family doctor, and automatically everyone registered in this institution gets a part of the financing what they're getting from the state. But the services are in general, in total, provided only for 24% of population, which we think it's a discussion topic. And we are right now already with Ministry of Health, and I thank you so much, Odetta, that she is really continuously keeping us on discussion. However, we think we need to do some more quicker decisions in respect of those patients, in respect of those children who has right for state-funded services, but they are just not getting them. So back to the number of the dentists and back of the service providers, I'm sure that accessibility in total, it's very, very good. And even if it's not about the dentistry, but Lithuania last year was announced as the best country worldwide where the medical support is the best accessible within all comparing with any other country. It means within 1 hour by car we could reach any or at least one medical institution and get the full support, one or another. So we think the same about the dentistry, but it is not clear how much we could use the state support. Yeah, okay. Accessibility of the primary oral health, you already saw this picture with the additional year 2021, which we haven't as per now, but I'm sure we will, on later stages, we will have it. But you can see that when we have 2.8 million population, so the general number on top line, you can see it's decreasing. It's decreasing and it's not as big as it looks. But when we put these numbers, the population and the percentage of the population, so here we have exact numbers, how many people are really getting the state-funded primary oral health. And even in this already several times mentioned survey or the document what the University of Berlin and other colleagues done, of course, those numbers are not so much comparable because of the sources where they come from. Our president, Vilma Brukienė, she already mentioned that too much concentration is on the treatment, but not on the prevention. And that's, again, one of the results. So any person of on the pension age or any person who has a possibility to get some state-funded support, they are eligible for 620 euros per 3 years to get for prosthetic works. They also have a possibility for orthodontic treatment, dental sealant programs, emergency assistance. But when we talk about such services, it's also important the division between the state-funded and non-state institutions is that if I, as a specialist, will non-state provider, I'm not participating in NHS or National Health System, if I send to some specialist for consultation, the patient lost the possibility to get state-funded consultation on the second or higher stage. It's again one of the discussion topics what we need. These numbers you already saw. It's how it looks, the financing of our dental market, and you can see it's continuously increasing. However, I'm sure that the numbers, general numbers, are not enough. Even if out of all GDP is nearly 20% allocated to the health system, and 4.5% are going to dentistry. And here are the numbers. So what we are raising up a question always, so what is a primary oral health and how much it costs? So it's 22.15 euros for the children and 24.2 euros for the children primary oral health if include oral hygiene. We already discussed with some of you before, in between our talks, that it is a problem to provide oral hygiene services for 2 euros per year. It's impossible, because there is economical calculations when the 1 hour of the oral hygienist costs round about between 50 to 60 euros. And if you want to ensure good quality oral health services, you need at least 1.5 hour, or I mean 2 times, 1 hour and half an hour. So 24 hours, it's not possible. And maybe that's one of the reasons why there are so small number of the participants in this NHS field, because nobody can't assure. And the second important thing is that if you agree or do the contract with the state, it means you can't refuse to give all services. It means there is a special list which you need to fulfill 100%. If you don't do that, you have no chance to have this. So again, another point where we need to discuss, of course, emergency assistance has some amount of money, but that's it. When we talk about the primary oral health and the financing, it means it's quite complicated. If we talk about elderly or adults, the amounts are much less, but of course it has some additional costs which the patients could pay. I will not stop so long on this slide. Here you can see the development year 2013, year 2021, how much money was allocated for the oral health. So when we start in 2013, it's 31.1 million euros, and last year was 54.5. And as a final remarks, I would say that the high number of service providers, dentists and oral hygienists is a great benefit and the base for a better oral and overall health status. However, the shortage of primary care providers results low accessibility. And when we talk about inequalities, which is on the last years is so much on the all health politics table, we need to talk about this. We need to make sure that the bigger part of population are able to get state-funded oral health services. And you already mentioned during a previous session how much important, and like the German examples, you don't need to have so expensive prosthetic or any other medical or dental services, because you invest much smaller amount into prevention. So low intensity of financing and unhealthy dependencies from primary oral health care centers is not attractive for service providers, and we are better to choose do on private level and attract persons to come by our professionality, by ability to propose quality of our services, and they do that. And they do that, as you saw the numbers, it's quite clear. And what is really in this, especially, crisis, another COVID, economical, Ukraine, energy crisis right now, is always asking to save money whenever it's possible. So when we talk about a household, so it's the biggest amount of financing is going on the household. And we think, again, we should find some better ways together with our politicians to support our community in most as it possible. I think that's very short, but hopefully informal.
Informative. Okay.
Informative, yes.
So now the floor is open for discussion. Maybe do you have any comments or questions from our guests? While you are thinking, I would like to add to Bronius that I'm a believer that there is no better mean for motivating patients as financial means. Well, I mean, that's why I liked Estonian example. Well, our government gives money to the clinic and says you must do everything for this amount. And your government gives directly to the patient. I'm not saying physically directly, yes, but the patient has right to choose how to spend this money on his or her own needs. So what we are doing now, we are offering to our health ministry to not even if you don't give us more money, but we suggest to reorganize this. Because I think that we are one of the last countries in Europe declaring that dental treatment is for free for everybody. So, and we suggest that maybe it's better to leave only dental hygiene or dental prevention for free. Well, nevertheless, the German says that nothing what is for free motivates, yeah. But still, and working and physically healthy adults, they should pay for everything with regards to restorative treatment. Well, because now they are paying only an additional for disposable, for dental materials, and of course, it's very, very difficult political decision. But maybe it's time to do this, well, because we see our neighboring countries and their examples. So we are the last ones who paying for everything. So, and let's do better oral care for children, elderly, I don't know, other compromised, socially compromised groups. So, of course, it's very, very, it would be a very brave decision from the side of politicians, but I think that it's time to do it, well, because we are ruining our oral health care in Lithuania. So maybe some other comments?
I could have a comment on that. As you can saw from the presentation, what we have done in the past in Denmark, we are now in a situation where there is a lot out of pocket payment from the patient. Almost every kind of treatment is paid by the patient. Yes. Why did we do that? Yes, because we, in our negotiations with the government, said, please understand, you don't reimburse the dentist. You reimburse the patient. You are not paying us money. Maybe we collect a part of our money directly from the national health insurance. Fully understandable. The patient doesn't have to pay and wait for the reimbursement. We do that automatically. But you reimburse the patient. Please understand that. You are not paying me a fee. I'm not an employee. I'm an employer, I'm self-employed, I own that. So I think this is very important to stand on. What you are doing not for the dentist, for the patients. And you cannot have all for nothing. that you can always also learn from the Danish model. Is it a problem that the patient shall pay out of pocket? Maybe I can only tell you what happened in Denmark, and then you can do your minds yourself. Back in 2008, there was more or less a ban of the use of amalgam in our countries, which means that we needed to do composite fillings. It was very cheap for the patient to pay for an amalgam filling. It was only a few Danish crowns for that. The prices went threefold high as we started only doing composites. And everybody said, oh, you cannot do that. You have to do a bigger reimbursement for the patient. Otherwise, there will be so many untreated teeth out there. Did that happen? No. Didn't happen. The patient paid the bill. Oh, yes, you can say, Freddie, you live in a very rich country, so it's easy to say that people have a lot of money. I fully understand, but you also have to understand the pricing in Denmark is on a total different level. If you go to my office and you want to have a filling in a molar, MOD, as three surfaces, and an injection, you pay 250 euro. Do patients do that? Every kind of patient? Almost every. So you can say to the government, you maybe have to learn it. As I also said this morning, you cannot copy, but you can learn from what we have done. And then you can find a Lithuanian way to come there. And you can maybe not move there in one step. You also heard Pia saying, we don't do group prophylaxis in Denmark anymore. Maybe you cannot start doing that immediately because you are in a total different situation. If I shall compare our DMFS with your DMFS, we are below 1 when we are talking about 12 years old. When we are talking about 15, we are very, very low. That's the reasons why we maybe can have a system like we had. So don't copy, learn from it, and find your own way through. Because as you're also hearing me saying, I know both systems, the German system and the Danish system. Both have good sides, both have bad sides. There's not one system beating them all. You have to look at your population. Where are you for the moment? And what do you need? And then you can learn. It's easy to say learn from the best, maybe. Yeah. So
that's why we are here.
Yeah.
We try to learn from the best our colleagues. But one of the proposals, what we proposed for the Health Ministry, for Ministry of Health, that maybe it's a time to let the patient go whenever he wants, and just say that you have such amount of reimbursement of your services, all the rest you pay yourself. In most of the cases, even of the children cases, nearly 50% of children, they do so. So why not to implement that on the whole market, and then you have more players in the market who provides such services, and then we really could say, and we don't need to hide that we have not enough money as a country to sponsorship all the medical stuff. Even if we talk about the adults, we are saying, no, it's not free of charge. But it is, every patient needs to pay for material, for everything, but the cost of the doctor is the highest bid in the general price. So it means looks like, in a way, we became one of the most richest countries in Europe because we pay the cost of the doctors when you're getting the state-funded services. But of course, we will find a way, and I'm sure the more findings, the more we talk, the more findings will pop up today.
And I would like just to add that I believe that this way of financing sends the message to our patients that you are not responsible. You don't need to take care of your oral health. Well, because if you are not taking care and you need extensive restorative treatment, it's okay. We will give you much money because for prosthetic. You saw the numbers. There are almost nothing for prevention. However, huge amount of money for prosthetics. So it does not motivate our patients to take care of their oral health. And I think that we still have some misbeliefs left from Soviet times still. Of course, with generation, they are changing. Well, because in Soviet times, the person was, there was no must to take care of oral health, well, because the government took care of oral health, yeah? So, and we still have some peer and some, of course, they getting older, and we do have new generation, but still the misbelief that I have to do nothing for taking care of my oral health. So it's still vital. And this misbelief that oral disease is inevitable still is vital. So, but we hope that things will be changing soon. Birgitta?
Me too. I have a few remarks due to patient basket. As you said, of course, we should look, and the National Patient Fund should recalculate, and the patient basket should be fixed not to the institution, for example, primary healthcare center, but to the service. Yeah, to the service. And if the patient doesn't use, for example, primary oral care, then that the doctor doesn't get this payment. If he uses also the calculation per capita per year, I think that's it's very effective in primary health care, but not in dental care. And those prices should be relooked and recalculated. And of course, that prophylaxis prevention should cost more than prosthesis than treatment. It's a big work for the National Patient Fund. And of course, we shouldn't expect the very quick changes, because the mentality doesn't change so fast.
Thank you. If we're on time, I find the discussion about income replacement, which is providing patients money to be able to choose their provider, very interesting as a potential solution moving forward. But I think that when one frames a reshuffling of the current basket of services, is also very important to take into consideration the political aspects that are implied on that. So one very interesting example that comes to mind is, again, back to the case of Germany, because it's got such a comprehensive coverage, is the coverage of prosthodontics for people in need. And I believe that the exemptions, the cases in which the law is broken for people that particularly require it, also help to balance the calculation and say, well, yes, we will have this potentially number of services that have to be paid for those that are capable of paying, but then the same rule gets broken by offering those in need, those that are unable to pay for their own oral health, the extra subvention. And this was the case with the Doppelzuschuss, the double compensation for prosthodontics in the German system, that actually, until very recently, was reviewed, and it had exactly the expected effect. It was a very successful policy in a way, because those that were in highest need were more likely to make use of it. And the result was that it led to better oral health for financially disfavored sectors of the population. And those rules making are very relevant, not only from the financial point of view, but also from the egalitarian and social aspects that have to be considered.
So do you mean that it would be great if, let's say, prophylactic in Lithuania, it's very much important, and investment in that is very important, to make it as a long or decade or 2 decades lasting strategic political agreement? That's what you suggest?
No, I wouldn't dare to give you any form of suggestion. Please do not understand that. I'm just mentioning, when it comes to the discussion of how reshuffle baskets of benefits, that as important as changing the rules are the exceptions for which we're willing to contemplate the exceptions for. Okay, so a rule is as useful in policymaking as to determine who should benefit and who should, have to, at the end of the day, carry with their own bill. Now, when we have created, or when a law gets passed, the exemptions in the system also bring up an aspect of equality that makes it much more palatable, and sometimes is the successfulness in German negotiations in the willingness to find a compromise or a common ground in which one could say when everyone is unhappy or a bit unhappy, a negotiation was successful. A very German saying, if you like, however, very fruitful if one has the mentality to find common ground for reforms in healthcare.
And I would like, oh, sorry, okay, Odeta, you first.
Good afternoon, everybody. I'm Odeta Vitkūnienė from the Ministry of Health, Director of Personal Health Departments. Thank you very for possibility to be with you and sharing experiences from each country. Really, it is very useful. At this moment in Lithuania, we have a national healthcare network reform, and in this part we are talking about patients' right to choose services. And when we are talking about dental care, it is big attention to prophylactic and to find the best solution how our healthcare system is based on solidarity principle. Yeah, and when we're talking and Ministry of Health are responsible for four directions. It is personal health services, public health services, health insurance, and pharmaceuticals policy. And when we're talking about oral care, I would like to put on also two parts. Public health services in Lithuania, we have in each municipalities public health bureaus who are responsible how to change behaviors for children in the garden, behaviors in the school, and etc. It works good or not. We have to put more efforts to this area and pay more attention. And also, when in the morning Vice Minister have shown about results that our consensus was prosthesis. It is result of our healthcare system, how it works 1 or 2 decades. And I agree that we are on the step of the changes, and we need social, social partners together, and with the political also efforts to do that, because of course we are on the step when changes is needed in our healthcare system, especially in this oral care. Yeah, thank you for possibility.
Thank you for your comment. And I think the changes are needed also in the minds of a dentist. So, and here comes my question, which I forgot previously, and for you, Professor Benz. So you've mentioned that in the 90s, you have switched dramatically to preventive dentistry. And my question was, so what was the driving force for dentists to change? Were German dentists so conscious and preventive driven at that time, or something or somebody forced them to change their activities?
A very good question. It were the chambers who gave some driving forces, but I think it was the being ashamed that dentistry didn't work. It didn't work. You made fillings, and 1 year later you renewed the fillings because there were caries and nothing worked. And we have had the same problem with periodontitis, which we actually only now really brought to a newer level. It didn't work, periodontal treatment, and colleagues said it's completely ineffective to clean the roots and so on. It does not work. And now we see it works if you do it the right way. And I think this being ashamed that things don't work. We made fillings and fillings and fillings, and you saw the patient again, and everything was gone, and you had to pull the teeth out, and everything ended with prosthesis. And this is not the way that I think. A very good question. I really never thought about what gave the impulse. It was not politics. Yes.
Yes. I worked in Germany at that time, so I also have a little bit of self-experience from that time. And as you know, I came from Denmark, where we have another kind of approach. I think it's of course about how we are educated. That you are totally right. That's about the mindset in the head of the dentist, no doubt about that. But you never have to underestimate which key point indicators you set up. So if you run a dental office in a business environment, and that's how it's often done, you always have to take care about how to earn the money. So if you pay the dentist a good amount of money for doing treatment and prosthetics, and a low degree of money for doing prevention, then you have, in my opinion, a key point indicator that doesn't work. Because what do you want to achieve? Prevention and sickness control, but you pay the dentist for doing treatment. So if you want to do something, you have to change the key point indicator. And then you have to pay the dentist or the dental chairside assistants or the dental hygienist for doing prevention. Because if you don't do that, they will continue doing treatment. Sorry about that, but that's the world.
Yeah.
Maybe I could add something. I'm not quite sure if money really was a starting point. Every dentist had to have his own billing for this, and which was not used. The colleagues were not used to this in the early days. So there were many dentists thinking that this is not a good idea. Prevention might kill everything else, and you have to give the patient a bill which he is not used to. So there were many forces against this, but nevertheless, it grew up and it worked. And I'm not sure, but maybe it's just this good feeling. You look in the mouth and say, wow, my filling from 2 years ago, still looking fine, no caries, and oral health is on the rising. So maybe it's that. I'm not sure if it started with money from the beginning. I'm not sure.
Maybe it should be a combination of dental education, the role of universities as well. Well, actually, we're trying to educate them in a preventive way. However, almost everybody just dreams about, implantology. If you ask a second-year student, first or second-year student, why are you here in dental education? Oh, I will be a specialist in implantology and I will earn a lot of money. And nobody wants to work in pediatric dentistry or in preventive dentistry. So something is wrong. Something is wrong with. Yeah, in orthodontics, as well. Yeah, please, Piret.
I think I'm agreeing with both of previous speakers. I think the education is very important, that we educate our dentists. I think it's the basic of dentistry. Is really, you are oral health physician, and oral health is part of general health. And to really, parallelly to the education, to really the ethics of our profession, need to be, I think, more and more highlighted in our education. But another aspect, what I wanted to ask you, maybe you have it already very well in Lithuania, of course in other countries, but I think what is lacking also is the education of the patient, of the population. I tried to speak years already to our health funds and ministries that we need to have strategy of health, but among these, very important is to have a health education. It needs to be in a school when the children are able to learn it from the first year until the last. And to educate what is the health, how it is my responsibility to take care of my health, and what is disease, what are the complications, everything, that they really understand that how important it is also to take care of your oral health. Because what has been, I've seen as a doctor with my patients, sometimes patients don't want to pay because they need to pay in Estonia. They don't value preventive measures. They say, why it was taken from my insurance money in my first visit when I had a hole here, but she was cleaning my teeth. This, for me, why this? I wanted to have a filling. I wanted to have a filling. So it means that there need to be two educations parallelly. And it cannot be only that the dentists are educating it, because anyway, it can be that, okay, dentists, they want to talk like this and that, or sometimes want to have money for prevention, or they think that it's not necessary. But if it is parallelly also the education of the population, that they understand how well it works for them, that they value this work as a prevention and they want to learn. Yeah, the younger generation nowadays, I think they are learning, but the big problem is the nutrition. But they don't understand that it's also a very big part. That all these soft drinks and sweets and these things. Snacks. And when we talk about it, it needs to be also in the society educated, that it is very important. We try to even talk about the sugar tax and our, I think, food industry association was attacking in a public TV dentist, our previous president, for that, because he said that there should be a sugar tax to really put this money to prevention, to use it really for the oral health and to have it, and also part of it is the education. I think, I don't know how it is, but in Estonia it's really missing. And I think it's a big problem that people just think, I can drink, I can eat, I can be 200 kilos, I can do whatever, and you, doctor, you need to take care of me, my way, as I like, and it should not be painful, and it should be cheap. So, and it is really the mindset, I think, what has changed. And our students, when they come, it's the same in our university. They dream of implantology. But
and orthodontics. I
think it is even when they enter the university. But of course, this all media is showing this kind of, like you saw our dentist. It was just published, 10,000 euros salary.
No.
Why no?
Yeah, but this year actually it was 11,200 for orthodontists, the highest salary in medicine altogether. So, and that was on all media, and that's attracting young people, yeah.
Educational problems are the same in Lithuania, and we have so many dental hygienists who are not working according to their specialty. So Lithuanian Dental Chamber actually offers as well we have to send dental hygienists to schools, to visit the schools regularly. Well, because we have to raise our children with healthy teeth. It would be enough one generation, and then they would have their own children, and already the things would be changing. So yeah, but I've heard about your comment, yeah?
I only wanted to add that thank you for the healthy self-criticism, and I think it's very helpful for the healthcare policymakers to communicate then with the dental society. But also about schools, of course, children should be taught at schools how to stay healthy. But also a lot of things starts with families and within families. And if children will see their parents brushing teeth, most likely they will also brush their teeth. So, but old habits die hard, there's a very nice song from an old movie, so.
I'm really happy to hear about that we need to educate society, just people in each of our country. And of course, it's our duty. I will speak about it a little bit during my presentation. But I believe that hygienists, somehow they could do it, but also very important is, and we do it with success in Poland, because we have a chamber together, physician and dentist. We cooperate with physician, with other doctors very closely, and they do their job for us. They are good advocates of good oral health. When the patient has other problems, cardiological problem, vascular disease, when they are before any operation, they get the information from the physician, from the specialist. You have to go to dentist. Give us the document that you don't have any problem, because without it, the operation could be postponed, or the success of the operation will be not as it should be, and it's work. I'm a practitioner, at my dental office, okay, every of us have a list of patients, but also I have a lot of new patients, because other colleagues, physician, doctors, specialists, go and check your mouth, and it does work. It's really good to take a cooperation with other specialists on medical market, with due respect, with hygienists. When they go, we did it in Poland in past, and it was not successful, because when the hygienists go to children garden and they say, oh, you should do it like that. It's okay. Children are fun with that. When they come back home and the parents, what you are doing, who told you? It stopped. So it should be education with entire family, and examples should go from parents, grandparents, because just a visit by hygienist children, it's work for a very short time when you don't have background from the family.
Concerning restructuring and financing dentistry, we have also proposed our authorities several times that this 40 euros support for adults who are working and are healthy, that is not meaningful motivation factor. So that is a kind of political decision. Our politicians, also earn votes by these popular decisions. And we suggested that this money should be used to have more support for people with special needs, not just this 85 euros out of 100, but, to cover more treatment and to minimize risks on general health altogether. So that is when you are doing now changes, that is one recommendation from our side.
Thank you. So, would you like to make some final comments?
Yes, just a small comment on this early age communication and training. What we find out ourselves when we do also nearby in some places these trainings. So we find out it's no reason to educate children without parents. So it's much more important to train the parents, and the early they do that, the better the outcomes. And I know that the state some years ago already initiated very nice initiative, and those pregnant women, when they are going pre-birth trainings, they also getting the education of the oral health, which is, we think, is very important. But we're just adding all most important things into one to find a better result.
Mare was showing before, we now established this kind of oral mouth university. This is basically focused on adults, because we have seen that if we educate the children only in the kindergarten, the parents say, at home, and they don't care, but then we need to parallelly have this education. But I think what was the strategy meaning was that the future, we should have started like this, that these children who are today in school, they become parents, and they are already these parents who are responsible and who know. And they know that this is their responsibility to educate their own children, and then they have a healthy children. So
Yes,
it was
of course, I
one
agree.
way.
But the whole family should be targeted.
Yeah, but unfortunately, we wanted to have a special videos which could be in the media, but health insurance it's not very actively supporting financially, I would say.
Okay, so thank you very much for all of your insights. But let's finish with Lithuania and go to Poland. We have the last presentation in this part, and I would like to introduce Dr. Anna Lela, a member of Supreme Medical Council and Center for International Cooperation, Polish Chamber of Physicians and Dentists. Please.
Labas rytas. At least this I could speak in Lithuania. Dear colleagues, to start with, I would like to thank the organizer of this conference for the invitation and for the possibility to speak. One more sentence in Lithuania. I'm not sure it will be correct. Ačiū už pakvietimą. It's my pleasure to be among such a group of experts of representing the National Dental Organization as well as regulatory institution. At least at the beginning, they attend to this meeting. As we all knew very well before this conference, and as we heard during the previous presentation, the financing of oral health care and its delivery is a very complex issue which involves many stakeholders, not only dentists and the dental teams. We have different approach among European countries to how the oral health system should be organized and financed, what was stressed many times during this day by Freddie. I will give you a brief information how the situation looks in Poland. As people before me introduce a little bit apart from my activity on Polish and international organization, I'm just a dental practitioner. I'm self-employment dentist with 2 specialties with general dentistry and periodontology. So I'm not a theoretical person, I'm just really a practitioner. I will give you, of course, some data which are needed, but I will rather try to formulate some general remarks from the point of view of the country where the oral health has not managed to find its proper acknowledgement with the general health system when it comes to, of course, public money. When we start the discussion about oral health care, we often begin with analysis of the finance aspect. We ask ourselves, should dental care be financed from public sources or rather from private sources? And already we discussed a little bit about it. The scope of public finance dental care, in other words, what dental procedure, if any, should be paid for with the public insurance scheme is continually being discussed, especially in times of crisis, when cost of living are quickly going up in every of our country, and other issue than healthcare gather public interest. And of course, we dental practitioners would always like to be able to provide care to our patient as often and as extensively as possible, as we know how important oral health is. I think we may draw a general conclusion that what almost all systems of public financing of healthcare have in common is that they allocate scarce resources for dental care. Maybe Germans are a little extension, but it's like that. We could ask why it's go like that. Most probably because oral health and as a result, delivery of dental care is often neglected, sometimes regardless, more likely a kind of cosmetic activity than a real health care. Even we have a CD statement that dental care is not a luxury, it's a must. Dentistry usually stands at the end of the line following other more important fields of medical care. When we discuss that we need money for dentistry, they always give example, cardiology, oncology is more important because people are dying, and about the dental care, nobody is dying, almost nobody, because we have some cases. As regards the public system of dental care in Poland, I will just give you just a few issues. The National Health Fund is the single public payer for healthcare in Poland, based on the money coming mostly from the statutory insurance contribution paid by individuals and in some part on money from the state budget. And for dental care is gradually allocated less and less money on the entire whole yearly budget. And there are examples that in 2008 it was almost 4.5% of funds budget, and plan for 2023 is less than 2%. It's about percent of the money, because when it comes directly to the money, you could show, okay, it's coming up, but you can buy less and less for this money, even if they are somehow growing. For the public payer, oral health care of Poland, of Polish population has minimal significance, and we have somehow positive list of procedure which are paid by National Health Fund, and it is paid only in this dental office who has a contract with National Health Fund. And on this list we have, for example, now the amalgam is forbidden, but when amalgam filling was existing on the market, you could take only front teeth with white teeth fillings, and molar and premolar were only with amalgam fillings. Root treatment was also only front teeth was covered by insurance. Next, people had to pay by themselves. It was an extension that pregnant women or children, they could receive any endodontic treatment when it was needed. When it comes to prosthetic treatment, partial denture could be covered by public money, but when you have over 5 teeth missing, when it's less, it's not from the service. And such prosthetics, very basic one, could be changed, replaced every 5 years. Any extraction is covered by national institution, so it's not a problem. Also scaling, just very basic removal of tartar. And what else? When it comes to orthodontic treatment, on the positive list is just orthodontic treatment with removal applies up to 12 years. When children are older, it's not covered. You have to go to private orthodontics, and there are some preventing procedure. But absolutely they are not satisfactory for us. And when it comes to money, we could say that per person is per year something about 20 euro, but it's somehow it's not true because just a few people go to public service, so finally they could receive more, and those who are not visiting, they don't touch this money. And also somehow it works at rural area, because at rural area when there is dental office who wish to be just private, maybe the citizens, there is not enough citizens or not rich enough to pay privately, so when they have a public service and the money is given by insurance, they exist in such rural areas. So somehow it's work, because when there is a question about number of dentists, don't kill me, I am not able to answer we have too much or too less. It's a constant discussion. It's when it comes to public money, we could say we have too much dentists. When it comes to private market, we could say, oh, strong competition. When it comes to rural area, there is not enough dentists. When it comes to big cities, oh, it's too much dentists. When you ask one dentist, you know, maybe they want to increase prices and they don't want to have a competition. They prefer to have a long list of waiting patients. When you ask, oh, it's enough dentists in your city, oh, no, too much. But why they send children for dentistry, if they say like that? So it's very, very complicated. Whenever we discuss about number of dentists, it's really very, very, very complicated. So the public payer oral health of Polish population is, as I said, not very interested in that, but also they have an excuse not to pay too much for dentistry, because we have some kind of tradition that people go to private dentists. It's not that it changed very much. It was always like that. That when you when you want equality, you go to private. And dentistry, even as you mentioned, Soviet time, it was the only branch of medicine that it was always strong private. So it's like that, approximately 20 or less of dentists have a contract, percentage of dentists have a contract with National Health Insurance, and everybody and other dentists work only on private market. And the Polish dentists don't want to sign a contract with National Health Fund. First of all, because the money are not very much attractive, but it's not only the reason. Even I believe that the more strong reason that they are not going to take a contract, apart from the money is limited, but also about the bureaucracy. Freddie said that our work is 30% bureaucracy. At private office, okay, we have also a lot of administrative work, but not so much. And when you go with public money, the report, the all administrative work, control, everything is disaster. So the bureaucracy is somebody that could kill any dentist. I believe that we were educated to do our dental job, not to fulfill papers. Somehow paper, whatever they are on the screen now, but still papers and bureaucracy. It could be quite interesting example about emergency dental service, because some time ago, it was a question from Hungary how it works in each European countries, and I had to answer to Hungarian colleagues about it, and for me it was even interesting how it looks when it comes to public service. So emergency dental care finance from public service is available at those dental office who has this kind of specific contract, and in this contract is that patients are treated in emergency case on weekly days between 7 p.m. and 7 a.m. just during the night, but also on Saturday, Sunday, and any public holiday, 20 hours a day. And when you ask politics, Ministry of Health, okay, everybody have possibility to get such a service, so they are happy about this. But the reality is that we have 41 places throughout entire Poland, so it's like something on the paper, because it doesn't work. Of course, patient could get such a service, but still on a commercial basis and private, because when there is the 41 places like that in Poland, it's like almost 1 million potential patient to get it, and I'm sure, as you said, that 1 hour drive in Poland it will be more. In my view, regardless of the healthcare system we have, it is essential to raise awareness of the significance of role of oral health, both among the authorities and the society. And this is really the key message delivered over the last years and even decades by us, by dental organization on a national, European and global level. And we have to continue to underline that securing good oral health of population really is cost-effective measure in general healthcare delivery, and we should, especially with authorities, talk like that. That when they somehow spend money or do any promotion among citizens to go to dentist, finally it will be cost-effective because they will spend less money on other branch of medicine. From a number of studies carried out in the last year, we know that for the majority of Poles, good health is one of the main values of everyday life. And they are also aware that they are themselves responsible for taking proper care of their health. So we just talk about it. But also we know that even if they understand that they are responsible for their health, somehow they forget it when it comes to visit a dentist, and approximately half of population visit the dentist once a year. But even though we know it's not enough, but it's like that. Basing on my long experiences practicing practitioner and as a national and international advocate of oral health, I can say that we, dental practitioners, are the only group of people who are seriously taking action aimed to raising awareness of the significance of oral health and its links to the general health care, how they exist. And I believe that it should be done in the first place by patients themselves, but of course we have to teach them. And it is in their best interest to receive good quality, comprehensive and regular dental care, not only treatment, because treatment is not okay, but any prevention. And our role is to make them aware of this, to make them know that good oral health is not only about lack of pain and nice smile, to make them understand that good oral health helps avoiding other diseases or limiting their burden, and in consequence, looking from an economic perspective, the investment in oral health is an investment in general health and well-being. And I believe this argument could be very important to our patient. If we achieve this, or maybe I should rather say when we achieve this, we can expect that public authorities and insurance will be forced to pay more attention to the prevention and funding dental care within insurance schemes. And patients who become more attentive to their oral health and starting treatment is as one of their life priorities will be ready to accept the cost related to dental treatment. Proper awareness of a significance of oral health and its influence of overall health spendings is crucial for satisfactory development of oral health. So I believe we should repeat it over and over again. And that's all when it comes to the presentation. If you have any question, welcome.
Thank you very much, Anna, for your presentation. I just want to make one comment. It was interesting fact that the majority of Polish people, they admit that they are responsible themselves for their health. However, half of them, they do not visit dentists, and I know the reason for this. Well, they were very honest in answering those questions, but historically somehow general health and oral health, they are separated, absolutely separated. And then they talk about general health, they do not mean about oral health. So yeah, that what happens, I would say, in all nations.
I just show honest how it is.
Yeah. Please, your comment.
Just one remark on that from Anna, because last year or this year we had the WHO discussion on the question on the part of dental health being part of general health. And this was quite interesting in German media, because this was one of the first times that dentistry came in the mind as being part of it. And probably this is something you could use of it, because this is now quite new within WHO. And we also, another remark on the question on the positioning of parents or families. We still have this group prophylaxis, and we know quite exactly that depending from where people come, the cultural background, it's very different how often they use the group prophylaxis for their children. It totally depends on the parents. Mm-hmm. So 2 or 3 years ago, when the beginning was 2015 with people coming from Syria, we were working together with the German Ministry of Health to work out for programs how to bring information to people, like being anxious of bringing their children to male dentists because of whatever the question is. But I think there are very good points that could be of interest, especially WHO, I think.
Okay, thank you. Any other comments or questions? Yeah.
I also would like to come back to Professor Ben's speech and what you stressed. It's somehow also in Poland work that what you have for free you don't appreciate. And when you pay, okay, you could complain, suffer, it was expensive, but you appreciate it. And when it comes to prophylaxis, it works like that. As I mentioned, I'm a periodontologist, and sometimes, patients don't understand what is scaling by hygienist, and when they visit periodontist, somehow some people call us higher educated hygienist. We could just make a fun with that. And when they ask about how much it will cost, I say the price, and they say, "Oh my God!" But when I finish, they say, "Okay, it was something." So they feel the reason, the difference, and they are ready to pay when they see the quality and they appreciate it. So on the one hand, we wish to have more, especially for children, for free, and it should be like that. But on the other hand, it's no appreciation when it's free. You could get it, and it's value nothing because it was free.
Maybe I could have a comment on that too. As I totally share what you are saying. What's totally for free has maybe no value. I think that's a little bit true about that. But you also have to think about dentistry compared with other things. I'll just give you an example. The discussion we have every time, and we have also seen that in figures today, that the people are saying they don't want to visit the dentist because it's too expensive. We also have this discussion in my country, of course, although there is reimbursement, as you have heard, for prevention, examination, and more or less nothing for treatment. So what do a young Danish adult use for visiting a dentist a year? You have heard the figures. Around 300 Danish crowns a year. It's close to 40 euro. That's the normal amount of money to pay for going to a dentist. You could also see in the presentation from Pia that they will now go making dentistry for free, not until 18, but until 21. So the majority are paying 40 euros a year. 70% of this young generation, we asked them to pay by themselves 40 euros a year. Now they will get it for free. Maybe that money could have been used clever. But you can also ask them, how often do you go and get your hair cut? A year. How much money do you spend for that? How often do you, in the weekend, go as a student earning a less of money, not much money, you go to a cafe, drinking a beer, a glass of wine, which is very expensive in Denmark. How much money do you use for that? And in both cases, you can multiply with 10. We have done that in the Danish Dental Chamber. So you land about 600 euros a year are they using for that. But they find 40 euros for dentistry too much. Why? Yeah, it's not only about money, they don't see the value. So you also have to work with it. So if you come from a country where having dental disease for decades for the biggest part of the population have never been a problem. And it was for free, because the dentistry, as you know, in Denmark for children are for free. We don't see the value. We have never paid for that. And now somebody asks us for pay for it. We don't go. And what happened? They don't come. They come when they are 25. And then we can do again, in the young generation, root canal treatment, tooth extractions, and what do I know, although they are well educated from school time. So it's not so easy to work with prevention.
They will learn and go to prevention later on, so some people have to learn.
So do you mean that you are going back to group prophylaxis soon?
No, I certainly don't think we will do that. We will not, but we will also have to understand that we have a small group where we have to do something else that we do now. But let's find out what we will do. We have to teach the government that you cannot prevent it totally, you can control it. So you need to use money also in the future.
But the nice thing with dentistry is when you neglect it, it kicks back.
Okay, so thank you. Oh, here's one
just-
more comment. Yeah.
Maybe a comment that's complementary to the whole discussion is the economic perspective of this discussion, because it brings me back in the day when I was studying as a health economist, not only as a dental practitioner. And I was learning from a proper authority of the NHS that dentistry was a luxury good, because the demand for it grew when the income of the person grew. That means that you expect people in an economy that's not particularly developed to not consider that a priority. And therefore their willingness to pay is very, very small. But this willingness to pay starts to increase very rapidly as a country starts catching up also financially. And that triggered a very interesting discussion on my end that was looking at also the clinical component of it. We had a very interesting discussion going for many, many months. And to this day, I think many of these economic assumptions have spread to the way in which policies get designed, and it's very hard to reverse them in a way, because the resistance, for example, for sugar tax is a very interesting phenomenon, yet it's also a global phenomenon. No country sees simple the inclusion of sugar tax, and yet we have very solid evidence to prove that they work, because they reduce consumption of a good that is substitutive, and people find alternatives to sugar. They consume less of it, and as a result, they have a lesser need for it. So, to bring it back on the same topic, the difficulty of merging together the educational aspects, the financial aspects, and the healthcare aspects is what requires for every healthcare system to also accompany by the side of the dental chambers, the, so to say, growth of policymakers to develop the right policy at the right time. And that is, I think, a very, very complex aspect that, going back to my previous point, requires that we have good institutions independently assessing and also good data, without which we will not inform in absolutely anything. We will have in the same discussion in 20 years' time.
Thank you. One more comment? Yeah.
I already mentioned that cooperation with other doctors, physicians is very, very important in this issue, because it's really strong message to the patient that they have to visit, that it is serious. When I am telling that, okay, you should, okay, doctor, say. But when the cardiologist will say like that, oh my God, I will go immediately. So it works. So my advice is to get in close cooperation in each of your country with physician, with all specialties, because it's very important. Not for us, because we feel very well without it, but for patient and for general public money, it's really very important. And now I don't remember the title of the article, but it was calculated in the United States, because they calculate money very much, and it was research when it comes to periodontal diseases and cardiovascular patients, that those who had proper hygiene and visit how it should be periodontist, their health problem were much less expanding, and also they cost the hospital much less. So it's this economical perspective that when we speak with authority, there are researches that we could show that it's work. If they want to save money, for them it's good to spend on dentistry, or just to information, education that they should go.
Yeah, actually, it's called interdisciplinary prevention, something like this. Yeah, well, because we need to work together. Okay, so thank you very much. So we have another break, and we will be back in half an hour for final wrapping up. So.
coming to the final stage, the last hour of our talks, and I think it's mandatory once again to say everyone who is participating, thank you so much that you join us. For anyone excluding, anyone including, for us it's really very much important, and we already spoke with Piret how we miss such meetings because it was stopped for some years. And not only because of COVID, but also because of different other circumstances. And we talked with Florian that we had some intensive period when we discussed so many important issues, and one of those quality of services, indicators of services, and it's really would be good in the close future continuously to discuss such topics in wider circles or in a smaller circles. But the experts of WHO is also for us so important, especially after your great survey, what you have done. However, we still have some questions not clearly and covered, yes. And one of those, the very special topic of today was financing. I know that the Germany has a very strict, clear and simple financing model. Could you be so kind and shortly just present how it is? Thank you. When possible, not in French.
I should have stayed in Riga, I think.
Too late.
Okay, well, actually, it's not so easy. I just prepared an email to a Croatian colleague today because she was asking me the same question, so I have the words in my mind. Actually, we have, as others explained to their system, we have two systems. We have the general system, about 90%, and there is a, let's say, there's a fixed tariff. So if you are, after a period of 2 years, practicing in a general clinic, you are able to be member of this general system, and you can work, and you're paid by the system, by the general insurance companies, but not by the patient themselves. So normally there's no money going from patient to dentist directly. The second pillar is the so-called private system. And this is much bigger than probably in other countries. It's about 10 to 11% of the people in Germany are privately insured or paying all their bills via out of the pocket. And in both systems, you have a, let's say, you have a general agenda of all those treatments that are normally that you're paid for, and then you have special treatments like implants that you need either as a private extra insurance or that you're paying by yourself. But both systems are obligatory membership to all dentists. Both systems have fixed tariffs, and those tariffs are set by law. Because European law, you're not allowed to have fixed tariffs that are set by associations or chambers. So this means even if you are allowed, like Austria, for example, has also tariffs, but they are not obligatory. So they have something like there's a suggestion how to be paid, but you have not the right to make the bill concerning that tariff. So in the end, and that's the very interesting thing, and there you can see how important this private sector is. Even when we only have 10%, 11% of privately insured people, the income in the practice is about more or less 42, 46% of the whole income. So it's more or less half and half. Within the tariffs, you have the opportunity to say you have a price for a normal treatment, and if the treatment is needs more time, is more difficult, you can higher your income. You can say, okay, I have 10 euro, but because it's so difficult, I say it's 2 times, so it's 20 euro. Then you have to explain something, then you get the money normally. But you always get the money either from the private company or a private insurance company or from the general system. The financing of the two systems is the general system is tax paid. So if I get my money from Christoph Benz, then the state says, okay, 14 point something goes to the social security system. This is the social system. And if I would have a private insurance, I would not be forced to pay this, but I would have to pay the other insurance by myself. So that's the financing, that's how the money comes out. And normally, instead, the only exclusion is the out-of-the-pocket money treatment. This is something where no system is within. And that's more or less what we have.
Please, can I maybe complement something, this fantastic explanation? The statutory system is incredibly complex. I had to learn it by heart when I joined the government myself. There were many things that were not clear, so I even had to take an additional course on law to be able to understand it. And it's very, very complicated because we have 104 different insurances in Germany that are public ones, and you are able to choose. So there is a catalog of services that all these insurances have to cover. And these public insurances are represented by one top institution that sits together with another institution that represents the insurances on the dentist side, which is the National Institute for, so it's a KZBV. So it's the insurance on the dental side. So they sit together with patient advocates, and this committee regulates, and they determine that if a certain treatment is positive, it has to become part of the positive catalog. And that means that it has to be offered. And there is also the mandate of being able to be self-regulated. So it's a system in which these two institutions, the insurances and the Dental Insurance Association, sit together and negotiate an appropriate price based on time and materials necessary. And this price is negotiated. Once it's fixed, the price for the technician is managed at a federal level. But the one that is managed at a national level is done by this statutory association. So then what happens in practice is, because of data protection, also these institutions don't have full access to the information. And in practice, all the money goes to one big bank account that's publicly disclosed. And then whenever a dentist wants to make a claim, they do the claim directly to the Dental Insurance Association that does the auditing of the data, but they don't have the data of the patient. So this association very strictly controls that every single position that has been created on the value-based care system is requested in due form and time. And normally they can claw back money. So it's an aggressive form of clawing back money. And that also ensures very high quality of treatment, because you know that you're being observed consistently, and there are many, many standards that are very clear. Every dentist that wants to participate in this contract has to know the system by heart, and it's a very difficult one. So when that has happened, and these people have already obtained this license and they want to claim their money, this intermediate dental association that negotiates in the dentist's behalf also gets paid through that, and then allows you to claim the money. And then when that happens, they make the claim and they send it back to the dentist's bank account after a number of months. So it's not necessarily simple. It's incredibly complex, and it requires a lot of institutions, and there are many ways in which things get troubleshooted. And I think that's...
No, I want to ask, as it looks like you are attracting and involving private insurance companies, and because you want to help patients to save some money, or not?
No, this is an important point. So these 104 insurances, they're all public, which means that they can operate making a marginal profit, but they have to fulfill all the legal mandates. And basically, what they do is they get a capitated fee adjusted for the variables of the individual. So for example, if I am a person that has a high risk, I'm reported as such, and I receive the insurance receives for my insurance, so for insuring me, a fixed number. And this insurance can also not reject me. The problem is that 90% of people are insured through these public manner, and this taxation contribution to the public system is progressive up until 5,000 euros, I think. So it's like 60,000 euros. If you make more than that amount, you can opt for the private system, in which case you get reimbursed. But only those are the private insurances. You have to differentiate between the 104 that are public and the other ones that are private.
Okay, so my question is then in this regard, the state covers some costs. The checking twice a year, full oral hygiene once a year, and some fillings. That's correct?
Yes, it's not really the state. It's every person in Germany who is member of this statutory insurance system has to give some money that he earns, and his employer gives some money too. And this is the money which is highly regulated, then given to the doctors. Yes, that's the way. So it's not really money from the state, but in some way you are right. Because the system is smaller than the money that is needed, more and more, unfortunately. In this year, we have 17 billions, American billions deficit, which has to be, paid maybe by the taxpayer. Yes, that's true.
Thank you. And I see there is some comments.
Yes. The way I was a little bit laughing was you were asking somebody to explain maybe the most complicated system that we have in all Europe. But there are similarities, and there are especially things you can learn about it, because we have a total different system in Denmark, but the way it is built up is more or less the same. If you look at the services that they have in the catalog in Germany and that we have in Denmark, more or less, basically it's more or less the same. But the way we are getting paid are different. So we also have not a per capita, but a performance or per service pay. And we have three categories of services. We have the services where we have examinations and tooth cleaning, where there is a reimbursement for the fixed prices, which means the patient will always get a bill for his 60%. The last 40% is paid by the government, more or less, but in Germany it's maybe for these specific services 100%.
By fixed rate?
By fixed rate. Then in Denmark we also have root canal treatments and fillings, where there is a fixed reimbursement that is paid by the government, but the patient gets the full bill, but the prices are very different. But there is a reimbursement. And more or less, if you look to the German catalog, you will see the same services: crown, splint, removable. And so it's more or less the same with the catalog, but the way you have made the financing of the system is absolutely complicated, and you are totally right. You have to have another study to understand that.
Great, and we will invite Jesus to show the system, or maybe the Ministry of Health will invite, or the Parliament will invite him for this. But for me, is the most interesting part on these cases to ask. The money goes after the patient, after the procedure or for the service, not per capita, not per yearly annual billing or something like that.
Normally, for example, I'm in the general system and I have a second private insurance for special treatments. I never see any bill. I go to the dentist, I go to Christoph, and he treats me, and that's it. I go back, and that's all. The only thing I see is that I have to pay 40.6% of my income to the social security system. Yes. But that's why for people, I think it's quite interesting, because they don't have to deal with it. They just go there, they get their treatment, okay, they have their pain probably, but the rest for them is quite easy. There is no bill they have to check. In the private system, you have to check everything in advance before you get the money reimbursed afterwards.
Thank you. there are any other
But only if you're interested. Well, we have one presentation in our office where we tried to explain the system in English. So if you're interested, I can send you the 127 slides.
Really?
No.
Yeah.
But it just okay.
Yeah, that would be a great advantage. It's a long night reading. Okay, and after that, of course, then we plan the visit to Berlin to see how it works. Before we have a big treatment, because you said when you go to Christoph, you always get free of charge treatment. So it's something. Yeah. Is any more comments on that? Because I would like to ask another one. Someone of you, are sorry to forget who, but the aging of the doctors, the nurses, was also on the table, and it's also a big issue for Lithuania. We have some numbers, we have planning system, and we have a colleague, Povilas, who is participating in some planning process. But it's quite complicated to explain for the politicians how necessary it is to have a dental assistant nearby, especially when the Danish example shows that there are number is double than doctors of dental assistants, when in Lithuania we have double less. We are missing so much dental assistants. So this topic for us is also very important, but also the age of doctors. And if we go a wider spectrum, so the family doctors has even more bigger problems with that. Are you facing any similar challenges?
I think I was the one who mentioned that in Denmark we can see in the next 20 years. In the next 5 to 10 years, 20% of the dentists will retire. So I also told you that we are working with planning. So the health minister has a very good overview over how old are the dentists. So yes, we know that in Denmark, and I also heard that in the CD world, as from also European countries, that we are having a situation where we have a lot of elderly dentists who will be expecting to go in retirement in the next years, and the new generation is not that many. So yes, that's a part of the problem, no doubt about it. But you also talked a little bit about dental team, because you are totally right. That's the reason, in my opinion, why it is so difficult to compare between countries. You can see from our country, we are using a lot of dental hygienists. We're using a lot of dental chairside assistants. You exactly do the same in Germany, although we have a different financing system. The way we work with dentistry are more or less the same. And without it would be not impossible. The way we run our office, we are 2 dentists, we are two dental hygienists, and we have 5 chairside assistants in our office for 4,000 people.
So, quick question, do the chair assistant need to be somehow educated additionally by formally or informally, or how it works?
Yeah. So in Denmark, if you want to be a dental chairside assistant, that is education from 3 years. 3 years. Then you are also allowed to take X-rays. You are allowed to do supragingival cleaning, and you are allowed to do impressions. And because that's a part of your education. So again, it's very difficult to compare, because we are using our auxiliaries totally different as in many other countries. If you go to the figures, you can see in some countries there are absolutely non-dental chairside assistants. Then of course they need maybe more dentists. So that's the reason why I say we also need to talk about dental team, also because it was you saying here, the new generation of dentists, why do they want to be a dentist? Yeah, so without thinking about prevention, I don't think they shall be a dentist, no doubt about it. But on the other side, I also think we have to accept that some of them choose to be a dentist because they want to work with high technology. They want to do all that stuff that is really a dentist. I also wanted to do that kind of dentistry 40 years ago, so I fully understand that. So maybe, and that's, I'm again happy I'm sitting very, very, very close to the door because I really am a dentist and I'm president of the European Dentists, but I really think we have to think about the future dentists should maybe have a different profile, also because the next generation want to have another profile. I'm really not saying that prevention is not important. Absolutely not. I'm also not saying that the dentist shall not take care of prevention. That's not what you're hearing me saying. But I think it could be otherwise where we can organize that we also can give the next generation of dentists what they want without compromising having a strategy based on prevention.
Yeah, thank you. It's actually the same as we have in Lithuania, 3 years education, post-education, and so on. But I see Christoph would like to add something.
Yes, I totally agree. We dentists learned to work with 4 hands, as it is called, at the patient, at our chair. But this is difficult from year to year, more difficult, because we have the demographic problems with young people, and young people don't want to have a job like that. They want to study and have a bachelor or master or whatsoever. So we compete with all the other areas where people don't need a bachelor or master. So it's more and more difficult, and I don't see any solution. Doctors have to adapt to the situation that we work 2 hands on the patient, which is already in France usual and in Belgium. And we want to visit them to see how they are educated, the dentists. And if I don't see there such a big problem. Of course, it's very nice to have someone to call and here, do this, do that. It's very nice, but I think it will be difficult in the future. Difficult. There are dentists in Germany who don't have anybody to help, or maybe only Wednesday and only 2 days, and yes, it's difficult. No solution.
So what do you do in Denmark to attract so many dental assistants?
I'm not saying that this is very easy to do. We have also been through a situation where it wasn't that attractive, but it also maybe has to do about that we are giving them the possibilities to do something else, but not only sitting next to the dentist, what shall I say in English? You can sit there and you can suck out the saliva, and that's everything what's in your job. We can see that. We have never had problem where we live recruiting new dental chairside assistants. We built them, we built them out also because we have a school for that in Kolding, where we live. We have never had problems, but now we can see if we don't offer them the opportunities to do something by themselves, doing a little bit tooth cleaning, maybe doing patient advice, maybe doing an impression, doing something more than only being assistant. Those practices who don't offer them a broader content of their job, they can't recruit them. But the practices that work more or less than we do, we can. That's one side of it. And then I have seen figures today what you are paying your dentist, that we are paying our dental chairside assistants in Denmark.
Oh, yes. Money.
Okay. Thank you. Anna, what wants to add?
There was a question about age of a dentist, and in Poland I could say that we don't have such a problem because each year we have more and more young dentists, so the future looks not so bad. We have such a problem when it comes to physicians because 1/3 of physicians in Poland are somehow retired, they still work. If they stopped, wow, it will be disaster. So it's, but it's not the same when it comes to dentists. I believe it's quite good when it comes to average age. And when it comes to auxiliaries, dental assistants and hygienists, it was maybe just a few years ago, it was a problem to find good assistant, good hygienist. And now, year by year, it's changing, improving, because new schools for hygienists were opened. And these graduates, students, I don't want to tell ladies because they are also men among them. What was quite new, because in the past it was only girls, and now we have a young man who also attend to a hygienist school. And now this profession become more attractive. It's also about money, because we as a dentist, we pay the money, and if somebody is good dentists have a long list of waiting patients. He and she understand that without support, it's no way to do it. So it's worth to spend quite a lot of money to have a good cooperating hygienist or chair assistants. So it's work like that, but we have also some problems, which is not easy to find a solution because of the regulation. For example, Freddie said that they are allowed to do the X-rays in Poland. It's according to the law, the X-ray should be done by dentists. We wish to allow them do it. Maybe some less official, sometimes they are doing, but officially it's not allowed to them. So it's a problem, because it should be like that, because for me it's a waste of time to do it. But according to the regulation, they are not allowed to do it. And the second problem is, not only in Poland, in many other countries, now hygienists, some of them, of course, not every, some of them feel like a dentist, and they want to be independent and open their own offices. And this is somehow a crazy idea. And whenever we discuss on international level about it, always French colleagues say, "Oh, we are lucky we don't have hygienists at all." But it's also something to which should be discussed. When we see what is good, we also should see what is bad. So if they want to replace dentists after 3 years of education without any responsibility and take the same money, it's crazy.
When we talk about this problem, I think in Lithuania, the aging for dentists is not a problem in general. When we talk about dental technician, oral hygienist is not a problem. But when we talk about assistants, here is a problem, because they are this part which doesn't earn money. And automatically they very dependent of from the doctor. And yeah, it's a big really issue, but just to understand how big a problem for physicians is, just yesterday before coming here, I talked to one of the children doctor, physician, and she said, "Can you imagine, yesterday I got invitation to go back to work. In my 80.5 years age, I got invitation to go back." So for some certain areas or specialists, it's really burden and it's really a problem. But I see Piret want to say something.
Yeah, I wanted to also give you a little bit of information in Estonia. I think our dentists don't go to pension because pension is so low that they prefer to work at least part-time. But anyway, we don't have a problem with aging so much in dentistry. We have more problems in general medicine. We really will miss very much doctors soon, and also nurses, but especially doctors, and it's really, I would say, it's problematic that they want to now enlarge all responsibility of the nurses, which used to be on doctors, just because to fill the gap. And the same issue, what I think it's, for me personally, very much touching for years, because of lack of doctors, they made this kind of amendment that they allow the students on the last year to go to work in hospitals, and it was automatically, because it's only one law, large to the dentist. The student who has been doing one root canal filling in his life, and as we have all private dentistry. And the biggest problem for me is that they let them so-called name as assistant doctor. So using the name of doctor, and they are not having diplomas as a doctors. They are undereducated, they don't have a basic education yet. In a hospital it's more easy because they are going with a doctor maybe, mostly, but they are already working sometimes in emergency care. Of course, students are very proud of calling themselves doctors. This assistant goes very silently, but the doctor is very loud. So there is a really missing part of the health professional in the nearest future. What I wanted to talk about nurses in Estonia, we have a lot of medical nurses working in dentistry, because hospital salaries are lower and dentistry is paying much more. So, and they are basically educated mainly in a clinic where they start to work. Now we have a possibility that they can go to the school to have special education on assistance. Now it is similar to Austrian system that they are working already, and then they go 2 years in some weekends they have education, but they basically practices in the clinics already. So to have a really assistance profession implemented in Estonia. Hygienists we educated once years ago in one private school, they are only 33. And the rest are now basically either some doctors give some responsibility to do some kind of work for the assistants who they have. But we agree with those hygienists who have a diploma as hygienists that nobody else can call themselves hygienists. Only those who have a diploma on hygienist, they can be as hygienists. Where I work, we have 3 hygienists working in our clinic, and I remember when we started to always to have this maintenance regular basis. Some of patients have used to come to me or my colleague to do these things, and now they are learned to go also to hygienist. But I personally think that we need to think very carefully how much we delegate and not to do it over, because this is it's not that like some very highly educated surgeons sometimes say that we are overeducated for prophylaxis and we are overeducated to talk to the patient about the oral health, and we are overeducated even to do so. These things I think are not right, because as we are the oral physicians, it's more than putting implants and doing orthodontic and prosthetic and nice things. Of course, they earn more, but it is a threatening trend if it is going like this. But I think we have seen also countries like Anna said, like in Netherlands, where hygienists are treating children already. And where's the limit, you know, if they have 4.5 years of education. Doctors now, dentists are 6 years now. To have a little bit bigger cap to avoid this mini dentist feeling, you know. So I think it is complex issue, like Freddie said, and in different countries is a different background systems. But let's not devalue the diploma of dentists and doctors, and keep eye on that dentistry is staying alive and is somehow regulated. And I'm very proud of Lithuanian Chamber that you are having this self-governance system here, that you can tell how it needs to be done and nobody else. So.
Hopefully. I know that Jurgita has just short question.
I wanted to ask, do you really do not have the lack of nurses in Estonia? Because in Lithuania, the lack of nurses is even bigger than doctors, and we have the bigger problem with the unequal distribution between bigger cities and rural areas. But actually, the absolute number of doctors is enough, and the nurses, we have a great lack of nurses.
We have also lack of nurses, and they now want to educate them more because the gap is very big, which is coming. So now they started to take 3 times more students for nurses because the education is shorter. To educate a doctor or a hospital, the minimum is 11 years. You can produce nurses faster. So they are already preparing change of law to give more responsibilities on the nurses. And in our family doctor office, you know, it's very difficult to get to the doctor because mostly you are communicating and everything is, the goalkeeper is a nurse there. So we have a lack of them, but they really now promote education, and it's have been popular to come to dentistry, of course. It's also a big problem for them. They don't want to give us these nurses who are educated nurses. That's why they agreed very well to have assistant education to avoid the medical nurses to go to dentistry.
Before we go with comment from Professor Mare, I think I have a solution for you how to keep more doctors inside the country. So it's a big trend nowadays. Just close the border with Finland and build up high wall. Professor.
And just a short comment. You said that assistants are low paid and that's why you are missing a lot of them. This last data for salary for nurses, it's half of the medical doctor's salary. And like hourly payment, 11 euros compared to doctors 20 euros. And in dentistry, dental assistants, nurses, so they are almost, there is no big difference, depends on responsibilities and how the duties are shared. It's 9.6 for dental assistants, nurses, and monthly salary average is for this year 28, which means 1/3 of the salary. But this 28 is of course due to the orthodontist's high salary. And I think that the, let's say, deficit with nurses, it's also a result of migration to Norway and Sweden, where nurses are well paid, and Finland also, our special target areas.
So to build a wall, it's not a bad idea. But Jesus, yes.
Actually, it fits very nicely. I would like to comment this more from the angle of as a health economist. The shortage in supply of labor is a big issue for pretty much all healthcare systems that are in high-income countries. And how it gets tackled is something also that we can learn from. You mentioned the example of Norway. The difference in terms of how much a nurse perceives per month of salary is estimated in Norway to be around 4,000 euros. And what the doctor gets is maybe 20% more. yet they do not have a short supply of nurses in Norway. However, Norway allows a very strict regulation by parts of the working guilds. So they're associated and they can negotiate their salaries. You cannot do the same thing in Germany. And there is a very rare example here, for example, in which you have long-term nursing homes where they get to bill insurances for a certain amount of money, yet they can dump wages as low as they want. And that has generated a choking point of labor that is very hard to overcome. So just now they're having to come to terms and say, people, you need to start paying at least minimum wage if you want to avoid this shortage. And the important point is that one unit of labor, so one nurse working 1 hour, has something that is very difficult to measure, because with doctors you see, well, how many root canal treatments has this guy delivered? How many surgeries has this dentist or this doctor performed? But with a nurse, you don't see that directly, and that has generated, when you measure excessively focus on key performance indicators, that corporate dentists, corporate managers and hospitals decide to give them too much work. What you see is that the best indicator to predict how good a hospital is, how likely you are to die, is how many nurses you have per patient. The more nurses you have, the better the hospital gets. So that's the balance.
Yeah, but it's always interconnected with the possibilities to pay. In the countries like Norway, as you mentioned, it is a wide possibilities to do so. But when we talk about the Baltic states, the Estonia, Latvia, Lithuania, so even if we compare to Denmark, to Germany, even with Poland, it's really complicated, and we're feeling a huge pressure from the public, from the politicians. We can't raise the prices because it's not possible to pay. So, of course, it's a big challenge for us, but I saw Florian wants to add something.
Only one remark. I do not know if you remember, I think 3 to 4 years ago, we had the discussion on European level raised from European Commission, where they started a study on the question how dental hygienists are organized on European level. And I think all member states participated, but in the end, the situation was so totally different from each other. For example, in Austria, dental hygienists they do not officially exist. Yeah. They're not allowed in Austria. Yeah. In other countries, they are more or less normal part of the team. So, but if I would look to the future of those questions, from the German point of view, I would rather fear that someday this question is coming up again, because in Germany this would mean we would have, first of all, really to change our law, because in German law it is said only the dentist is allowed to do, and he can delegate. The OECD saying delegation yes, substitution no. So this would really go into the heart of what the German dentists are doing. But I think this could be something like a start to look into the study that the Commission does in 2017, 2018, I think. Thank you.
Does anyone else would like to add something? Povilas, would you say some words, because you are in the process of planning process. You know, we have a special committee under the Prime Minister House, and he's participating in the group where they plan the human resources and some issues there are. Povilas, would you?
At the level of European Union.
Who will?
I didn't got the question. I couldn't hear you.
Yes, once again, do we have a possibility to regulate the quantity of specialists at the level of European Union? Because we are speaking about human resources.
So we have on a European level, we only have 2 recognized specialties, orthodontics and oral surgery. There have been requests that we could do more specialties, but that will not gonna happen. No, not for the moment.
So we can regulate just at the national level?
Yeah, you can do it on a national level.
And human resources we have a possibility to migrate from the Venezuela to Norway, from the
Also we only have 2 specialties who are recognized in all the European countries, the 2 that are even mentioned. But we have a lot of countries having more specialties than that. No problem. In Norway, I think they have 7, and in Spain they also have a lot. So that's not a problem that on a national level you will have more specialties. But on a European level, for the moment, there's no movement there. We have been talking about that with the Commission, but it stands to there will be those 2s and no more.
Okay, thanks for answering.
Just additionally that, in Europe, the medicine is regulated on the national places. That is the main principle have been, because we have a different financing systems also for medical field, and so that's why this kind of harmonization, even the students, once we met in Amsterdam, asked why we don't have a harmonized education for all dentists, and like every university should be, or what specialists are working in each country. Sorry, but it's by the European principle. It's not possible, at least now.
Thank you. I had, during our coffee break, one remark from our colleagues, and she told me to point out very special topic, because when we talk about prevention, about the investment in the prosthetic work and so on, it's quite a big amount. She asked me loudly to let's say announce or to say that still we have a position that preferably we pay for the prosthetic work for the children in full instead of investing in the prosthetic work. I mean, it's up to 1,720 euros per person could get the prosthetic work for the children, instead to invest some 5 or 10 euros, let's say, per person into every child. So it's a big team for us, but we believe in some time we find the best way, and now is on the way, as already Vilma announced and Odette announced, is a program, an oral hygiene program, prevention program, and we hope very much, we're looking forward that it will be done in the best possible way, just to avoid such really unbelievable, I would say things. But we are going to end, but I still have one question, which I think for Lithuania is very, very important. And we heard already some examples that people, like in Germany, they find out that it's so much needed to come on yearly basis for checkup. I know personally some Canadians friends, they do checkups on yearly basis strictly, because then otherwise they lose any kind of state or private insurance support. But we're still struggling in Lithuania with this topic. And may I ask you all, maybe every one of you could tell your magic pill, how to make sure that every the children is okay in Lithuania because it's calculated in the national register, but how to make and organize that adult age people on yearly basis come to check up for dentists, because it's really important if we talk again about the prevention of oral diseases, and knowing this special attention of WHO on the oral diseases with the systematic diseases. So it's utmost important for the system and also for every one of us that it works. So, and I see Christoph is ready to share some.
We have this bonus paper in which the patient, the doctor underwrites whenever such a checkup was performed, and if this is if there are no missing dates, the patient gets, I think, 10% more for prosthetics and so on. This is what we have for many years now, and I think it works quite good in this. And it will be digital in the near future. Yes.
The recall.
And of course, the dental the dentists very often have a system where they recall their patients. They just send them an SMS or WhatsApp or whatsoever, and tell them you should come in the next 4 weeks.
But in case you missed 5 years in a row, are you still able to get financial support from the state?
Yes, you are. Yes, but on a lower level. No, 10% less than those who have nothing missing.
Well, actually, it's a bonus system. You always get your 100%, but if you want to have 110%, you need to show that you have been there for years and years. I haven't been actually someday.
Oh.
When I was younger.
Yes, shall I tell you a little bit about the Danish system? As you heard from the presentation, that although we have a system built up where every child has gone to dentist many times a year since the early 70s, we only have 80% regular users in the adult population. So we call it drop out, and they are there. In Denmark, it is mandatory for the dentist to have a recall program. So every patient who was in my dental office, I am obliged to make a plan for how he has to visit me again. You saw the presentation from Pia and those 3 different groups. If he don't visit the office, I have to do a memory of the recall between 2 or 3 times. If I not do that, I can run into problems. So you will also see in every Danish record, there had been a recall patient invited to come for an annual checkup, didn't appear. And you can see it recorded, otherwise you would land in the situation by Pia when the patient after a couple of years says, oh, the dentist never told me to come and visit him again. So now I am in a situation where, and you can imagine what I will say. So this was one of them. But again, what to do with those 20% who doesn't come? Who doesn't come? Because if you have made a recall 2 or 3 times, you stop doing that. They are out of the system. We negotiated a couple of years ago that if they haven't been to a dentist in 2 years, it was up to the regions who are organizing this part of the health system to write to them. We can see, because there have not been any kind of reimbursement, so they really know if the patient has visited a dentist or not, because we have this totally control about everything in my country. So it's very easy for the government to find out if there have been some dental consultants or not, to vote them and to tell them, so it's a long time ago since you were by a dentist, it's time to go. But this hasn't until now solved the problem. That's the only 2 things that we have in Denmark.
In Lithuania, we have some kind of problem with people engagement in different programs. For example, early cancer diagnosis programs and so on and so on. Only about 50% of those who should come and get investigated comes. So how do you do this? Do you call physically, or maybe SMS or letters, physical letters or emails, or is it always a physical call from a doctor?
In the past, we of course did that with letters, but now our country is totally digitalized. I know the mobile telephone number of each of my patients. I know the emails of each of my patients. So we do the recall by email. But we also have set up our program. So if you have an appointment with me tomorrow, I will remind you about the appointment today through an SMS. So we have, I'm not saying this is the right way to do it, but you can see the responsibility that you visit your dentist. We have more or less taken this, and this is a little bit in contrast to that, sorry, it's your teeth, it's your responsibility. But we have taken over as a dentist a part of that. But we know that it works. When we have started going from where we didn't do something about SMSs, we have patients not visiting the office, 10 or 15% of our patients didn't appear. lots of time. I having a dental chair, I have my staff there, and I produce nothing. So yet we have said, okay, it cost me a little bit of money sending this SMS, but if I look in my book, I normally never has a patient who doesn't come for an appointment. So the money I invest for sending out those emails or those SMSs, I pay for that in my office. I fully understand. Out of my pocket, you can say. But again, I don't have an empty chair standing there costing a lot of money.
In Estonia also, it's up to the dentist, but it's not a mandatory, basically. Of course, it's a duty of the dentist to call, somehow tell to the patient that they need to come when they need to come again. So we have also the SMS system. It's linked to our programs, which are automatically sending. That is 1 year ago when you visited, it's time to come. And the same way, like Freddy said, we have 1 week before the call, another SMS reminder, and then 1 day before. It was really helping to change it. But we don't have any sanctions on that, and we have been discussing it with Sick Fund. Should we have some kind of more mandatory for also the parents to take the children? No. Nobody can be forced. It's very liberal, so we are not able. But we would like to have it, because it's a really pity if we see the army doctors are telling that boys come to army, full carrier's mouth, and they are released from army because nobody wants to take them to the army. You cannot have a sick soldier because it's not possible. And they tell that they never heard that there was free of charge to go to dentist. So again, it is coming, this education, I think, education of the population, that oral health is part of general health, that they really think about it. And I remember one roundtable in Portugal when previous Portuguese presidency was. We had from Commission many different people and expert scientists had presentations about oral health, part of general health. And when was a conclusion, then this one person from Commission said that what she learned during the day was that floss or die. So, so I think anyway, I think the education is to motivate them. I think if maybe part of it is also the finances. If they spend the money on this, they want to maybe more, they value more, and they want to keep the healthy mouth. But the problem is if it's only private service, we don't see maybe 30 or 40% of the population, because they have maybe a lot of needs, but they don't come because of their too low education, of even generally speaking, because they are mostly the vulnerable groups. And this we don't meet. This should be linked to the general health system, that they are called and by the family doctors to show this kind of initiative, that because usually everyone is visiting sometimes a family doctor or nurse, that they look in the mouth and say that, sorry, you need to go to the dentist. This could help in the prevention field.
Yeah, thank you so much. Nowadays, I'm sure it's all about effective e-health system, which really help us a lot. And this is an additional and very important issue for Lithuania right now. And
don't start.
I will not open the Pandora box for sure, but we have a hidden agenda in our team. When we were planning the teams or the countries to come, the Pirith was one of the first on the list, because she's so big expert of e-health, and even in CED you were head of this working group. So maybe I have a good chance once again to ask a health representative of Ministry of Health to show here is the best expert on the e-health issue in dentistry. It's not about the general medicine and the e-health systems. Okay, the calling system, everyone now, even taxi has the system, but it's question how effectively organize our works, and this reminders and other stuff. They looks like simple, but when you try to include them in the system, it always a question. So I will not open this issue, but if you find a second to talk to each other, would be great advantage, I think, for Lithuanian dentists. I see that we are exactly on time as planned, 4:30. And I need to ask, like, you know, before wedding in the church, does anyone has anything to add? If not, keep it with yourself. But have a good evening. But thank you so much to everyone who joined us. I'm looking forward very much that we can continue with such initiatives, and I'm sure that different countries, different knowledges, know-hows are with us. But I see before we stand up, Piret has some surprise. So, Piret, floor is yours.